How physically ready is your patient to return home? Totally ready, not ready and totally ready. That was maintained. Then the question 2, how would you describe your patient's mobility level today? Totally dependent, totally independent. Question 3, please. This is 3. I beg your pardon. 3. How safe is your patient when ambulating independently? All right. Totally safe. I mean, not safe at all. Very safe. How well can your patient perform transfers? Unable to perform transfer. Then can very well perform transfer. Just like that. Let's go to the last one here. How likely is your patient to adhere to physiotherapy recommendations? Very unlikely and very likely. So I propose that the total score should be 100, and then the interpretation, okay? The interpretation, 80 to 100 to be for discharge from the physiotherapy standpoint of view. Then 50 to 79 may require additional support or outpatient rehabilitation. Then below 50 will be considered delaying discharge and arranging intensive post-discharge care. So that's what I proposed, and it was accepted. So the permission was accepted, and that's why I adapted it here. And I'm sure by the time we have this, we'll be able to, from our own point of view, use this to, take a decision for the patient whether to discharge or not to discharge, or whether to, continue the treatment and to discharge the patient and continue, ask somebody to continue. So this one will help us to be able to sort out that. I'm sure this answers your question, sir. Oma. Thank you very much. As I said before, please, I don't want other therapists not to, to feel bad. I think we can as well adapt this too in our practice. You get the point? Because the sorry to say, Professor Weiss told me that they even use the nurse readiness for patient discharge scale. But the physiotherapists and occupational therapists use the nursing what do you call it? The nursing version of this particular readiness, and then they found out that it also work out for physiotherapy. However, I felt this is more specific for us. Okay. Now, another template that can be used for planning discharge of patients is what we call hospital discharge checklist. So this one has about 4 domains. The first one is getting help at home. Then the second one is the discharge plan. Then the third one, getting started and planning ahead. That's the first one. Then the second one is the health concern the patient has. And then the third one is getting help at home. And then the fourth one is discharge plan. So I'm sorry for that. Okay. Now, what are the indications for discharge? Having done this, you still need to look at other indications for discharge. Now, when your goals have been achieved, you get the point? When your goals have been achieved. So sometimes the patient will say, I am ready. Other aspect of it, he scored about 70% of it all, but your goal has not been achieved. Your goal is reduced, maybe 3, but he scored high in other areas. Will you still discharge the patient? And that is the essence of this particular slide. So you look at this achievement of goals. Once that is achieved, then you can consider discharge. When patient is stable, consider discharge. Then functional independence, consider discharge. When the patient can be safe, when he gets home, you should consider discharge. When there is someone who can help to continue the treatment at home, consider discharge. Then patient choice. At the end of the day, the patient choice to discontinue receiving service, no matter the score, no matter the score, has to be acknowledged. Very, very, very important. We said when you are planning discharge, the patient and the family must be part of the team of planning of discharge. So when the patient or the relation is vehement, we do not want to continue with this treatment, please discharge us. Or they just felt, well, they are okay now because of finance, because of where they are coming from, far distance and all the rest, all the bureaucracies. Therefore, they are coming with this suggestion. Please, sir or ma, can you just discharge us? You will not say because the patient did not score high enough, you won't discharge the patient. So this is very, very, very important. Now, the next slide is, that's number 7 of it, is when there is lack of measurable, benefits, you can as well consider discharge. What do we mean by lack of measurable benefits? It is when treatment no longer results to any benefit at all. You cannot measure any significant progress, even if you use your outcome measures. It's still the same. For 1 week now, see the same. 2 weeks, see the same. Why are you still keeping the patient? So at that point, you can consider whether to discharge this patient or not. But you don't just say, okay, go home. What you do is, first of all, review and analyze the aspects of past service that you have rendered and seek consultation. You get the point? You seek consultation. Maybe you are chief physiotherapist. You can ask your senior, who is the director. You understand that this is what you saw. That is at your departmental level or your unit level. You can as well seek consultation by seeking the opinion of other professionals, the doctor, for example. You understand? For proper review. Then what do you do? While you are doing that, you now modify your treatment. Probably the treatment regimen you are given is not adequate enough. You can remodify it and see whether you can get something better. When there is measurable benefits, let's assume there's measurable benefit. I haven't done this. If it is yes, then what do? You continue treatment. You understand? You continue treatment because you are getting improvement now. You are getting improvement, though not excellent enough for you to say this patient should be discharged. So what you do is now you continue the treatment based on your modified regimen. However, if it is no, even though you have modified your treatment, it's still no. What you do again, review. Maybe there's other thing you can do for the patient. Review, and it comes down again. If it is No, I won't say you should go back, except you have other things you can do. What you should do now is to discharge. There's no here. You discharge this patient. You get the point? So you don't need to keep a patient 1 week, 2 weeks, 3 weeks. The range of motion is still 30 degrees. Let's assume that's the essence the patient came to the hospital. You understand? He cannot do that. Why are you still keeping the patient? Okay. Now, when the patient is finally discharged, then you do a follow-up. So that's what lack of measurable benefits actually try to let us know. All right. Now, what's in different professions? They have different things they should consider in order to know whether the patients lack measurable benefits or not. For physiotherapists, if the functional goals like mobility, strength, and all the rest plateau despite intervention, you should consider what I just mentioned at the previous slide. For occupational therapists, when patients no longer show progress in the activities of daily living or adaptive strategies that you try to prefer, you can consider, you can, go back to that diagram and follow the process. For speech therapists, if communication or the swallowing goals are not met despite consistent therapy, you should also know what to do. And of course, psychologists and counselors, when therapeutic goals are not being achieved. So an alternative approaches and or referrals are which are more appropriate should be considered. Okay. Now, what are the logistics for patients' discharge and transition of care? There are logistics to take. And I'm going to mention two. Two of them before discharge and then after discharge. Before discharge, there are things we will do, which is as much as possible, early assessment and planning. We mentioned that before. Is the first thing you should consider. Begin discharge planning as early as possible. Then the patient's needs and preferences and potential risk should be considered. Okay. Then therapy should be involved with other teams because it's a collaborative team. It's not for you to just take decision on your own and then without also considering other team before you discharge your patient. Other team members before you discharge your patient. Okay. Effective communication. We need to give a proper communication to the patient. Patient must understand what we are talking about. We need to educate them and provide the necessary information and all the rest, as I mentioned before. Then ask the right question and identify solutions. This is the reason I'm even bringing this slide. The question we are asking must be right. We don't ask unnecessary questions. What are the questions you should ask? Why is this patient here? The patient, at the time the patient is admitted, one of the questions you must ask yourself is, why is this patient here? Now, another question you should ask yourself is, why is the patient still here? Maybe after some time you have treated, maybe 2 weeks now, 3 weeks, 1 month. You should ask yourself that question. Each time you are going to the ward to see the patient, the question you should be asking yourself, why is the patient still here? All right. Then what has changed? Allowing the patient to go home. What has changed? Or not allowing the patient to go home. You get the point? Then when will the patient be discharged and where are they going? These are the questions you must always ask yourself. You must, from the time of admission to the time of discharge, there are different questions you'll be asking yourself. So these are some of the logistics that are required. Okay. Okay. Then you must also find out if there's a need for you to refer the patient to another institution. You consider proximity. Then you also consider whether the institution you are referring the patient to is an accredited institution or clinics. You understand? Are they accredited? The individuals that are working there, are they licensed? The reason for this is for us to encourage ourselves. Very many of us are not licensed and we are practicing. It's not right. It's not right at all. You know what licensing means? Licensing means that you have gone through the continuing education program. Because if you don't do that, if you don't have your CPD points, you can't be licensed. So we are not necessarily telling you to, okay, go and get your CPD, get your CPD points. But we are telling you, go and get licensed, because indirectly we are telling you, go and update yourself. Some of us, it is what we knew 20 years ago that we are still practicing today. Whereas there are a lot of things that are new that we are supposed to have added to our education that we are refusing to go and get. So the institution must be eligible, where you are taking the patient to, must be eligible for you to ask your patient to go to that place. All right. After discharge, of course, what we expect is that the patient goes back to his community, to the house specifically. And what is expected is that we make also a contact. We need to make a contact. There is a guideline, that was given by in USA. It is called transition care management. There's a guideline for it under Medicare. And right there, what I saw is that the initial contact that they must make after the patients have been discharged should be done within 2 business days. In this part of the world, Nigeria specifically, how many of us do this? Patient is discharged. Your patient that you'll be seeing have been discharged, has gone home since 1 week now, and you have not called the patient. So we are trying to say that this area should be changed. Now, what is expected is that we do not just call anybody. There are 2 individuals we must put in mind when we want to make a call: the patient himself or the caregiver, or both. You get the point? And this should be done within 2 business days. Then, after about 14 days of discharge, there's a need to do a face-to-face visit. That means we just visit the patient. What do we do when we get there? Just do a comprehensive assessment and then do a personalized care planning. That means you have to plan again for this patient, the next goal you want the patient to achieve. So these are what is obtainable in the Western world, which we think we should begin to consider in our place here. All right. I brought this one for us to, it just summarizes all that I've said regarding the logistics. So I brought it for us to see the flow of activities from the time before discharge, sorry to say before admission to the time of discharge. Now look at it here. Pre-admission and admission, what is expected from the therapists or the clinical staff is to ask some questions. Have you completed, yes, just ask yourself a question. Have you completed a discharge needs assessment? You get the point? Ask that question. Then, have you recorded the contact details of any local social service provider for these patients? Blah, 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 like that. Then the last one here, between this pre-admission and admission, the last one here is, does the patient have any problem with mobility or performing activities of daily living? This one concerns with the physiotherapist. Look at it at the time of admission. Get the point? At the time of the admission. Most likely, probably the day they refer the case to you, as soon as the patient is admitted. This is what you should consider. All right. Now, when after admission, that is whether the patient did surgery or not, after admission, one of the questions here is, as the patient experience, I don't know whether you are seeing this. I just remember now. Let me see whether I can focus it. Let me see whether I can focus it so that we can see it properly. I'm not seeing, okay? Now, as the patient experienced any new healthcare event since admission, which would delay discharge, just like that. So these are the things you ask yourself. Then I want to see this particular one at discharge. Let's see, does the patient know who to contact if there are problems after discharge? All right, and all the rest, like that. There's another one that concerns us here. I'm looking at for. Let me see. There's another one here. Okay. Let me see it. Okay. There's another one here that concerns us. You understand? So, because of time, just take note of that. Now, the next thing is self-management. Self-management. After discharge, we expect the patient to continue the treatment at home. And that is why the essence of self-management, the concept of self-management came to be. And then we said that self-management is a component of self-care practices. Self-care practices means the ability of individuals, the families, the communities to promote their own health, prevent disease, maintain health, and to cope with illness with or without the support of healthcare worker. and that this does not replace the healthcare system. It provides additional choices and options for healthcare. So that's self-care. Now, what is self-management? Self-management therefore refers to individuals taking active role in managing their own health care. You have to take active role, and it's very, very necessary after discharge. So it helps the patient to recuperate and then manage themselves at home. Okay. Now, we can give task-oriented activities. Then we provide the necessary support that they need, the education and what have you, to make sure that they're able to carry that out. We do not just leave them without, that's the essence of even the calling. Sometimes you call your patient to know whether they are doing it well, whether they have issues or not. Then you provide the necessary instruction or advice so that they'll be able to carry it properly. While doing that, you are also, giving the necessary support. All right. So that will prevent setback and early readmission. If that is not properly done, patient can be readmitted at a very short possible time, which we are trying to discourage. Then what are the approaches of self-management? Then I categorize it into two: the physiotherapist's role and then the patient's role. Now, the physiotherapist's role, which I want to emphasize, is that we, the therapists, we should let patients have a final discussion with you, with us before they leave. We must allow patients to have a final discussion. Some of us are not making ourselves available, and it's very, very wrong. You'll be looking for physiotherapists or the therapist. The therapist is nowhere to be found. I don't know, most of the time we have gone to do our own PP outside. And this patient needs your attention. They are just be discharged. Maybe he was discharged early in the morning with the intention of a bath. Okay, let's just say a bath to be discharged early in the morning. Everybody knows that today he was going to be discharged or is going to be discharged. By 12 o'clock, you are nowhere to be found. And this patient needs to have a word with you before he will finally go. So what we are saying is that we must create room for discussion anyhow you want to create it. If you are not available physically, then phone calls. We should allow phone calls, text messages, email, and other. I want to just say something here because of what I also discovered that is not too good that some of us do. Sometimes we do not want our phone numbers to be disclosed. There was an individual that patient was not my patient. As the head of department, the relation came and was looking for the therapist that saw the relation that is hospitalized. Just wanted to have a word with the therapist. Was not around, and I have to give out. I gave the number out. Say, please, you can call this number. This is our number, which the relation gladly did. But to my dismay, the physiotherapist was not happy that I disclosed his number or a number to the patient or to the relation. My reaction to it is that, do you have your contacts at the board, that is notice board, on your call? She said yes. I said, now, why are you angry that the patient called you when your number is displayed there? So please, let the patient have a discussion with us. We are talking about the child now, that is final discussion, but I want to even just extend it to at every given point in time that the patient wants to address an issue that concerns them, we should make ourselves available. Very, very important. So let patients know if they need in-home therapy, that is home-based therapy. If they need it, you let them know. You get the point? Let them know. And then, in the Western world, it is incorporated into their system. You understand? Incorporated into their system. They also do home-based treatment. But in this part of the world, particularly my institution, it is not, it is a private business. We just know our patients need this thing, then we make arrangement with them, and then we continue, because some of them cannot come to the hospital. As much as possible, we encourage them to come. But there are others who cannot walk. So those individuals may need home-based treatment. So we can provide it. So let them know that they need it, and they need to continue, or they need to continue their treatment on outpatient basis. Now, let patients also ask about any restrictions that they may likely encounter after they have been discharged. Let them ask that question. So be ready to, respond to all the questions or concerns that the patient has. If you cannot provide solution, then ask somebody who is superior to you. You get the point? Very, very important. All right. Now the patient's role. The patient should consult with his physician at least for the last time. One last time. Very, very important as well. Patients are to make sure they understand any medication they are to take. Now, the patients may not have this knowledge. You will let the patients know that, look, before you go home, if need be, let me know. Get my point? Let me know, or let those who are working under me know. You can even sometimes direct one of your juniors and give that instruction, so that before they leave, they may ask that kind of question. But in this context now, we're talking about the physician. So the physician should make sure that the patient's medication are understood before they leave. Then they should also know the purpose, the dosage, then how to even take it by the time they get home. Now, the second aspect is that the patients should try to familiarize with the devices or equipment that the therapist prescribed. The patients are required to know this. And the physiotherapists, occupational science, and others should also endeavor to make sure that they give the patients the necessary education regarding what they prescribe. The instrument is described for their patient. You don't just prescribe with the intention of, when you are coming, come with that instrument for you to use at home, but for you to use in the hospital. You should let them also know how to make use of it at home. Okay. Then make a follow-up home exercise program. They should continue that at home. Then pain relief strategies, how to relieve their pain and what have you. Sometimes with physiotherapists do not do that. You can you can allow them to also consult their doctor to give them pain relieving drugs. Right, that's what I would just tell us, because I know that some of us physiotherapists, we also try to, give certain medication to relieve their pain before we do our exercise regimen on patients. But I don't know what to say because in some countries now they allow physiotherapists to do that. But in Nigeria, we have not been given the license to do that. I want to believe that we should advocate that physiotherapists also should begin to do the needful, because I told a medical doctor at the time I wanted to do a passive movement to a patient that has excruciating pain on the knee joints. There was a need. Yes, he has. It was this thing that he has contracture based on wound. He has what do you call it? Bones, very, very severe bones, and there is need for me to do passive movement for the patient to prevent contracture and others. The patient could not tolerate the pain. So we are at the mercy of the doctor, who will not be around at the time we wanted to carry out the, what they call it, to carry out the exercise. So I am of the opinion that physiotherapists, since we also do pharmacology, we should begin to advocate the essence or the need for us to be able to administer pain relieving drugs for our patient before we carry out certain exercises for them. All right. We can as well use ice, heat, and others. We all know this to relieve pain before whatever. So these are patient rule. They can as well do that. But for me, I try to discourage patients using ice. I try to discourage it because some of them can abuse it. There was a scenario one of my lecturers told me, which was a life experience of a patient, one of his patients, because the patient was seeing him using ice therapy on him, before other therapy would be done. And the patient went home. The person was an athlete, an athletic, how do I call him? Was an athlete, let me use that word. And they put the ice on the thigh for more than 30 minutes, And at the end of the day, frostbite and others occurred. They had to amputate the limb. Since that discussion, I just determined myself not to be prescribing ice for patients. So we have to be very, very careful, asking patients to take, for them to use ice on their own at home. Okay. Then the patient is supposed to also stay active. They need to monitor their symptoms. Then, do they even need support at home? So that takes us to this point, the needs and supports for patients and their family members. Now, physiotherapy should also take note of this, that family members play a crucial role in caring for their sick ones. You understand? They play very key role, and it's essential to provide support to them during these crucial periods or critical periods. What I'm emphasizing here is this: we are not even talking of the patient now. We are even talking concerning the family members. So as we are talking about the patient, we should also consider family members who are managing their sick one, because they can as well be traumatized psychologically. You understand? They may be having issues themselves because of their sick one that they are taking care of. So all the time they need this empathy to give them encouraging messages to the sick family member. Just be giving them that encouragement. They need it. Please, I want to just give this experience that I had very many years ago. There was a patient that was very, was having a challenge. Was healed, back pain or thereabout, the back pain, serious one, and then approached me. What I did, I just I said, look, this thing is not a life-threatening thing, because the patient was psychologically down and emaciating. So I just said, this thing is not a life-threatening issue. Just modify your lifestyle, your walking, the way you bend down, and what have you, and what have you. I didn't touch a patient. I only just give encouraging words. The patient didn't, that was because I met the patient outside, of course, not in the clinic. The patient didn't come again. Incidentally, the patient was a friend to my wife, and then sent a message to me to say she just discovered that she's okay now, that the word I gave to her helped her. You understand? So you see that some of the problems that the patient may present to us may not be necessarily organic. Yes, it could just be psychological. The fear of death and other things will now just cause certain pains on them. So when we give patient empathy and give them encouraging words, that's a way of helping the family. You get the point? And then, of course, even the patient themselves. Okay? Now, there was a research that was done by Sullivan and his mate in 2021 on the needs and their experiences concerning the his of their loved ones. And what was found was very interesting. They categorize it into three perspectives. The number one is that during the illness time, what kind of support do they have? Now, 58.8% of the family members reported receiving enough help and support during illness. And what was their comments? It was focused on the care of the patient received rather than support for them. At the end of the day, they said, well, the comments that these people were giving to them, well, they received it too, but they redirected the, what they call it, they redirected the what do you call it, encouragement to their loved ones that are sick. Okay, and they were so happy for that. Then the second category was when the patient died. At the time of death of the patient, they found out that 52.8% felt adequately supported during the heal of the patient's death. When the patient died, about 52.8% of them felt they were adequately supported. Then 14.6% mentioned that the imminence of death wasn't clear, affecting the ability to even present at the time of death. So at the time of death of their loved ones, they were not even there, because what will cause death and what have you, what they should do and what have you, was not too clear. They just felt maybe this patient will die and what have you, so they just left. So that's that. Then after death, the research also made us to understand that 25.2% had a follow-up conversation after that, which was helpful for the bereavement process. Now, 21% did not have a follow-up conversation, but would have liked to have. So this research tells us that there is a need, because they love it, for us to give support to the members of the family members of the healed patients. So that's the conclusion. Healthcare staff, conclusion on this is that healthcare staff expressing empathy, respect in the care of dying people and their family members are providing clear information are important for family members' experiences or expressing support. So we should not just be too concerned about the patient that we are treating. We should also consider the family members. As I said before, I want to repeat myself. It is not proper when the family member of patients come to the hospital and we talk to them rudely, harshly. We see a lot of us do it. Please, I need to say this again, please. There was a patient that was just coming from a very far distance. Let me just say, but I discovered the patient coming towards the clinic about 100 meters away. And I saw when he sighted me, he started laughing, smiling. He came and we now started having discussion. At the end of the day, what I just discovered is that the patient was just happy to have seen somebody who he think can help him of his predicament. The patient is coming with pains. And he was thinking that, how will I see a Messiah that will help me out of the pains? And he cited you from far distance. I want to tell you, even though there's no research basis on that, I want to believe that about, if not 20%, about 20% of relief have come to the person without even receiving treatment psychologically. So that's said, at the end of the day, makes me to say that patients, particularly their relations, need this support from us as therapists as well. They need it. It must not be money. It must not be money. There are other things in which we can do to support them, which I'm going to highlight very shortly as I'm about to conclude. Now, we need to talk about how we identify the needs and supports for these patients. Family needs and supports. We are not even talking about the patient now. We are talking about their family, the needs of the family. Then there is a tool that we can use to identify these needs and supports. It's not every patient that comes to you, he has this need or the other, you just say, okay, this person needs money, just give the person money. Maybe I will say something on that as I progress. So there's a tool for you to know whether this patient has a need or not. And if there's a need, how do you prefer solution to meet the need? So this tool uses 3 components: specification of family needs, identifying the sources of support. That is where you can get the support from, and then the resources, the people who can help to meet the needs. And of course, the staff roles in helping families access resources from their support network. That talks about you and me. How do we help the families to access resources, from their support network, which I'm going to explain very shortly. Now, this figure tells us about the approach, the social system approach to family level assessment and intervention. Now, this area line horizontally tells us about the needs of the people. We have income, we have food, we have clothing, shelter, whether the place is safe, whether they can access other health, whether they are, holistically, how is their health like? Talking about the family members now. Well, are they strong enough to even take care of their loved ones that are sick? And are they even employed do they have money, enough fund to be able to carry out whatever, because they are not employed, they're employed, and all the rest. These are family needs. Okay. Now, vertically here, we have the resources. What are these resources? The what they call it, the family, or let's say the patient himself, can be a resource to himself. I'll give an example. Some of them can be bedridden, but they have enough in their bank accounts, but they cannot access the money. Why? Because they cannot go. For example, now, they cannot do money transfer, probably because, a lot of obstacles. You get the point? So they can as well be a resource to themselves. They can say, okay, they can call any of the family member to assist them to withdraw the money. All right. Then the family member as well can be resource. Let's assume that this individual cannot provide for himself. The family member could be a resource. Friends, social groups, the professionals, you and me, then human service agencies, they can, those, non-government organization falls into this place and not the rest. Then policy makers, our legislators, all of them, they can serve as resources to meet the needs and support of the family. Then, of course, we have the professional roles here, diagonally. We have the teacher, for example, if it's a child, the teacher of the student, of the child in school, could be consultants in our hospital. There could be resource people, enablers, and all the rest. Got the point? We also fall into this category too. All right. Okay. Now, there are different conceptual framework of assessment of intervention of family supports. And these assessments of family needs and intervention synthesize different theories, from a number of social system models. Now, one of them is social network theory. What is that telling us? It's trying to let us know what are the social activities of this patient or the family, maybe a member of the family. Does it belong to a club, Rotary Club? Does it belong to, is he a university graduate and then belong to his alma mater, association, just like that. Some of us are Christians. Do we belong to a particular church? Then that church can serve as a source of which we can get help. If you're a Muslim, the same thing. You belong to that place. They can be of help as well. Just mention it. So Combining all these is what we mean by a social network. So these individuals can, one way or the other, provide help or support for the family. Then we also have what we call human ecology theory. This has to do with the interactions, between a developing person, somebody in a community, with the people around them or around him, and how the events, affect their behavior, how this kind of environment affects the behavior of the family member. For example, is in a particular community. There are places where once someone is not fine amongst them, you will see everybody in that community take it upon themselves to see what they can do to help the individual. So that's what we mean by human ecology theory. So we have help seeking theory. Somebody has a condition, he's sick, maybe his brother or what have you has come down with stroke and what have you. And because somebody is sick, in effect, because of that, he cannot begin to go out to be looking for help. That's what we call help seeking theory. And of course, we have the last one, which is adaptational theory, which means maybe an individual who is also growing in a particular community. For example, a child that is deformed, who has disability, let me use that word, and the family, has a way in which people in that community try to help them, and is the thing can affect his decision, whether positively or negatively. In some community, once they have a developing child that has issue, that child is not a child. Before you know it, you see that the child is dumped. For example, we're talking about cerebral palsy, for example. In my institution here, there was one particular woman. She just brought the patient to the hospital. And the next day, we didn't see the patient anymore. She, as I'm talking now, neglected the child. And the child she should be about, if I'm not making a mistake now, she should be about 10 to 12 years. And the child has been there since when the child was about 2 years. So what is the feeling perception? How can people tag me with this kind of a child? But some others, we say, well, now so we see them. Then they now adapt to what the situation they find themselves. So that one talk about adaptability theory, and the individual may now be seeking for assistance to help the child that is sick. Now, I want us to get this framework. That is the framework of assessing family needs. Now, look at this column, family functions, and then we talk about needs here. The economy of the family. Is it viable? If it's viable, this is what we now know to know that we use to know that it's viable. Adequate amounts of money, ability to budget money wisely, funds to purchase necessities and all the rest. Physically, adequate nutrition, that is clean air, water, and others. Then vocationally, access to telephone and all the rest. Recreationally, time for rest and all the rest. So we can use this to assess family needs. In case, for example, the patient does not have adequate money for it, we can say this family is not economically viable. Okay, we can use that. All right. But it's better to use this instrument. The other instruments used for assessing family needs, they are very, very many, but I want us to use this family resource support guide. It's very, very clear. Now, it's based on the theory, as I mentioned, supporting resource-based intervention practices. Now, it addresses the family needs and priorities. Then, the practices promotes family involvement in decision making. All right, when you are talking about the needs of family, for example, you do not just say, this individual needs money, just give the person money. He doesn't have clothes, this and this and that. Every time the patient is coming, you give you this complaint, you give you the complaint. At the end of the day, you need to know the needs of the patient holistically, and then the priorities. Which one does it prioritize highly? So this resource support guide makes us to ascertain that. Now, the practices promotes also family involvement in decision making, as I said. Then it promotes individual and family capacity to meet his, her, or their own needs by engaging him on them, taking lead role. I want us to take note of this. The family is the one that take the lead in identifying, mobilizing, and evaluating resources to meet their need. All right, and that builds strength actually. Okay, let me just go further. We are going to use that particular family resource support guide has 3 tools in it, so it's 3 in 1: family resource scale, resource map, and others. So resources can be formal or informal. Now, resources are types of community help or assistance that they need, which may include, useful information, advice, guidance, experiences, or opportunities, and all the rest you can mention, to achieve outcome, to meet their needs. All right, and it's a process and procedure used in identifying and gathering information. The process and the procedure used to identify and then gather this information and then mapping out the sources to meet these needs is what we call resource mapping. Okay, let me just continue. The use of resource scale is assessing adequate resources and all the rest. Now this is a typical example of the family resource scale. Now, we have here the instructions are given. Now, we want to know, for example, this is identifying areas of need and priority for that family. Now, one of the questions in this scale is food for 2 meals a day. Do they have it? Not at all adequate. It's not at all adequate. It's 1. Then if it is almost always adequate, it's 5. This individual said 3. That's what they have. Sometimes adequate. Now, house or apartments, do they have a place where they can lodge? The answer is yes, usually adequate. You don't have problem like that. Money to buy necessities, he said 3. Like that. Let me just go to the last one here. Now, child care day care for your children, he said 1. I repeat, child care or daycare for your children. What is he saying? Not at all adequate. You get the point? All right. Now, let us now begin to brainstorm items rated 1 and 2. may be taken as evidence that basic needs are not being met. Then the next thing to do is that the practitioner helps the family to select one of the priorities. You know, this individual, I'll go back, this individual has a conglomeration of a lot of needs here. All right. And we now said one or two of them is taken as evidence that basic needs are not met. Then the practitioner, what we do is to help the family to select one to five of priorities for the individual. So that this slide I want us to take note of. Now, which items can we consider as strength for this family? We can reflect on this now because of time. If you want to respond, you can go to the chat column and do that. Which of the items can we consider as strength for this family? Look at it here. One or two we said should be considered that they don't have the basic needs for the family. Okay. Now the next question is, which area or areas does the family need support? And then the third one is, which item forms as priority for this family? Okay. Sorry, I'm trying to see whether there's any. Okay. All right. No, nobody has responded. Now I'll go forward. If you ask me, I'll go back. This individual has this as a major concern. This is the major concern that must be sorted out for. Child care. Get the point? Child care. Now, let me quickly say this. When I was all the time in my office, somebody will just come to me that the child is just hospitalized. He doesn't have money to buy drug. Doesn't have money to buy drug. I should assist. My colleague, my fellow worker, though not a therapist, one of these junior officers, not just junior officers, at least is almost a senior officer. Sometimes I will give. Before you know it, another person will come. Some other day, we say, I do not have money to go back home. I don't have transport money to go back home. I will give. Some other time, another set of people will just come. So I saw myself giving out because maybe they just felt that I'm generous, I saw myself giving out until one particular day I have to talk to myself. So these people don't allow me to do anything. If I don't take a stringent step to stop this. So what I do was, I pray with the person. The last time the person came again, I have to pray. Say, sorry, I don't have. Now, the reason for my statement is to say that these individuals, they have other areas that they are meeting. You get the point? Food to them is not an issue. Clothing is not an issue. And probably because of one little area here, they are coming all the time to seek support. So we need to now redirect ourselves to know which area that is let's know what the individual has and what he can do. Let's know the capability of the patient or the family. That's what this particular scale is trying to let us address. Now, when we discover that childcare was an issue for this patient, so the second part of this scale is the resource map, as I mentioned that time. So which area is your area of priority most prioritized is reliable child care. That's what it stands for, reliable child care. Now, the informal resources and supports, how can you meet them? In order of priority, he said early head start, which means this is a name of a school. Then voucher money, to meet that. Sorry, I don't know what is marking my. Are you seeing the mark there? I don't know. I'm having a mark here. All right. So, in order of priority, just hold on, please. Something is disturbing me. Okay. Now, in order of priority, early child starts. That's a school. Then voucher, and then Auntie Linda probably has to take the child to Auntie Linda to assist. Maybe that individual will assist to sponsor the child in an education. Then the next one here, which you didn't prioritize at all, is find someone through church or trade. Okay, having understood that, then we now go to the next stage. Now, mobilize, identify resources. That's what we're supposed to do. Then we use family resource support plan. Then the practitioner assists in developing plan for mobilizing the identified resources, whether formal or informal. Then plan. The plan now belongs to and is developed by the family as agreed by both the family and the practitioner. It is the family that we develop it, and that will be in agreement with the practitioner. You get the point? What you only did was to help the patient to now focus on how to get the problem sorted out, rather than you are just put this in your hand in your pocket, giving out money like I did. I do not want to say those people were wicked, but I felt, look, you are meeting your area in other area, you are meeting your needs in other areas. Then this particular one, you are using me now to be able to meet it, and I felt that is wicked. Let me say, most of us are like that. They will have money in the bank. They don't want to touch their money that is in the bank. They will come and meet you to assist them, that they are hungry. We have a lot of them like that. And to me, if that kind of patient behave that way, I will say the patient is wicked. So this particular format will help you to overcome that kind of burden. So that's that. Then the part 3 of it is the family resource support plan. Now, at the end of the day, the individual was able to enroll the child in the early head start. He was able to do that. That he was going to do it the following month, because he had been able to achieve all the resources required So he was going to do it the following month. So how is he going to achieve it? He will apply, then the neighbor will assist. And who is that person? John or Jos rather. Then tax returns, and then birth certificate. These are the things that will be required for the application, because they will require your tax receipts. They will require the birth certificate of the child. And maybe at the end of the day, the neighbor, maybe it's not too learned, the neighbor who is Jos will assist to get it, haven't taken the application form. Now, what will you have to do to make it happen? Now, he said we pick the application, sit with Jos, and then return the application, and then what application documents? I beg your pardon. We will return the application documents. Now, when will that be done? The first one, pick the application on Monday, sit with those that same Monday, maybe in the evening. Then 2 days later, which is going to be on Wednesday, I beg your pardon, he will now return the application form. Then at the end of the day, how are we going to now know that you have accomplished your dream? When the child is accepted for enrollment in the early head school. So this is just a way and a picture of how we can identify family priorities and assist them to be able to actualize these highly prioritized needs for them. All right, I conclude. Final conclusion. So there is this paper that I also cited in my work. I mean, while I was doing this, when I was preparing for this workshop, by Goodman 2016. And there's something he said, which I want to quote. So, and I quote, early assessment, early planning, and coordination of all the teams involved in the patient's care are essential. Effective communication between the various teams and with the patient and their family or carer or carers is necessary. Patients should leave hospital with all the information, medication, and equipment they require. And in addition, I want to conclude by saying that support for family of all ill individuals or the ill individual should be provided in alignment with the family's prioritized needs, ensuring that their concerns and responsibilities are acknowledged and addressed throughout their care. So these are my references. Thanks for listening. So I entertain any question now. Thank you very, very much for giving me your time.
Thank you so much, sir, for this detailed workshop training today. We are very grateful. So if there are questions, please kindly raise your virtual hand up or you type in the chat comment section. Thank you very much.
All right. There are certain people that made some comments, which I want to read out. He said, I will still give more time to attend to his needs, probably involve other multidisciplinary views that he can benefit from. I want to believe when that when we are, I don't know when this, I don't know what was responding, what was responding to. Maybe when I was mentioning the area of priority of the patient, because I didn't see this that time. Okay, then priority is daycare. Thank you very much. This person mentioned it. Then strength is indoor plumbing. So he has strength in indoor plumbing. Let me see that.
Okay, there is a hand raised up here, sir. Mr. Sulaiman Aminu. Kindly unmute and ask your question, please.
Good afternoon, sir. Good afternoon, moderator. Good afternoon, everyone. Hello, sir.
Yes, please.
Am I audible?
Please, yes, I can hear you.
Thank you for the presentation, sir. My question is, I don't know, maybe.
I can't hear you any longer, please. Sorry. I can't hear you. Your network is somehow. Maybe you just type.
Network was on my side. With respect to, hello, am I audible now? Sir.
Yeah, I'm hearing that lastly. I'm hearing at the last time of your discussion.
Yes, with respect to things to consider in discharging patients, please, what is the place of compensatory management, conservative management, especially with respect to conditions that have very poor prognosis, like in case of neurological conditions? That's number one. Number two, you made mention of you advocate the you are of the opinion that we shouldn't be advising or prescribing cryotherapy to patients at home. So my question here, sir, is based on what we used to see day in, day out, like for example, in the case of acute MSK conditions, you see that patients are advised to or are prescribed to be using cryotherapy for 3 times in a day within the first 48 to 72 hours, and they do come up with a remarkable improvement. But if they have to come to the hospital or to the clinic before they receive cryotherapy, that will be just once or 3 times in a week, for example. So how can that be possible? Then lastly, hello, sir. Lastly, sorry, lastly is with respect to, sorry, what? Lastly is with respect to, sorry, maybe I've forgotten the other one. Or you can just respond to this too,
all right,
if I remember.
You see have the opportunity. If you remember, you can ask it.
Okay, sir.
The role of conservative management, you know, and if the patient has poor prognosis, the question is what again? What will be my role? Is that?
No, the question is, can we still discharge him even though he is supposed to be continue receiving physiotherapy in form of conservative management?
Thank you very much. See, I now understand the question. It's very, very good question. As I just said, talking about when there is lack of measurable benefits, you have your patient is in the ward, for example, and you have been managing, you have been trying your best. Now, this patient needs conservative treatment, and he has poor prognosis. Should you still discharge this patient? Now, the issue is this: you have to consider other factors. Now, you can't continue to be doing passive movement or what have you, conservative treatment forever in the world. Well, you have assessed the patient and you have your treatment goal. What are your treatment goals, even though it's a conservative treatment? For example, there are other professionals are managing, and the patient is still in the ward. You want to prevent deformities. You want to prevent DVT. You want to make sure that maybe the patient could not sit down, but you try to make sure the person sit down like that. They are all conservative. You can continue to hold on to that patient until others discharge the patient. When others are giving their nod to discharge the patient, you cannot say because the patient has poor prognosis and you want to continue conservative management, and then you now keep the patient perpetually, and you allow the patient to continue to burn his or her money. You must also consider the economy of the individual. So what you should do is to, allow the caregiver as well. You allow the caregiver or the family member to know what they should continue at home. You educate them what they can continue to do at home. Then at time interval, if there's a need for you to also see as a physiotherapist, you book them. They'll be coming once in a while. You assess. And if the family members felt that they cannot...
Okay, thank you very much, sir.
Yes, if the family members felt that they cannot continue to come to the ward because of the bureaucracies and what have you, then you prescribe home-based therapy for them, and somebody have to go home and then see. That's that. Now, ice therapy. It's true. What we encourage, during the first few days of inflammation, we encourage ice therapy. Yes. If you are very, very sure that the patient will not abuse it, if you are very, very sure the patient will not abuse it, you will give that serious warning. It must not be more than 15 minutes. So if it's more than 15 minutes, something like this can happen. What I do, if I know that the patient, if I'm not going to be around, I know that the patient will do it, I will just tell the patient, I will not give a kind of fear. Say there was a patient that used ice therapy and they amputated the leg. So ice therapy injury is even worse than heat therapy. I will educate them that I can do that. Then you ask them to use ice therapy. But as much as possible, in what they call it, day-to-day activity, because we still see some patients, therapists, one of their treatment plan is ice. All the time they go, they must give ice. That kind of condition, you will see that the patient will be tempted to say, my therapy no come today. Make I just use ice. The more I use the ice, the more I am okay. We are trying to avoid the consequence of that. That's why I use that word. So it is not an absolute contraindication. Thank you very much. All right. Najib, am I right? Your hand is raised up. Sani, you can unmute yourself and ask your question.
Good afternoon, sir. Thank you very much for this wonderful presentation. It was very educative. Actually, my comment is related to the first questioner, which is Dr. Suleiman Aminu, and it's related to discharge. Sometimes, sir, am I audible, sir?
Yes, please go ahead. I can hear you.
Sometimes we normally have patients that come to tertiary institutions for healthcare. I think they are on admission But then when they're about to be discharged, you find out they live in long distances. And this time we're talking about 200 kilometers away, and they have a tendency to want to continue post-discharge treatment in your facility. But their fear is if they discharge them and they go home immediately, will they have the transport to come back? So when they look at all the logistics, they inquire among each other and they come up with their opinion. Though, like even though the other health practitioner have discharged them, they want to still be paying bed fee. And paying bed fee means they are still in the hospital, of course, but no other like nursing care, the physicians, they don't attend to them anymore. So it will become only physiotherapy. So at this point, we'll try to like fasting instead of maybe treating them like outpatient, we'll treat them like inpatient. Still, we know they are no more on admission. They are only staying for physiotherapy care. So we'll keep them for like a week, saying, okay, after a week, you can now go home because by this 1 week, we'll do most, especially if the patient is like based on your that discharge scale you talked about, they achieve almost 90%. Some will say that they want to start, I want to remain in the hospital, I want to get much function before I go back. So in this case, you can't say you don't want you will discharge them. Like, okay, you can stay, you can pay the bed fee and the physiotherapy fees. We'll continue seeing you to a particular time, then you can go home. So during this time, we teach them a lot of home exercise program or management skills. So my question is that is this like is this normal or is this okay? Because other practitioners have already discharged this patient. This patient is now under our care, but we choose not to discharge them because of the vicinity issue. They are not close to the rehabilitation center. So maybe they are in a local government that to even get to town from the villages is difficult. So we want to get as much recovery as we can before this patient will go back. Others is the family member that's okay, this patient, even though the physicians have discharged them, they don't feel this patient is stable enough that we should keep seeing them. But we don't have any, how will I call it, any disagreement with the other health practitioners. All they know that they are not going to attend to this patient, but physiotherapy continue seeing this patient. So what is your opinion on this matter? This is what I just want to, this is my
Yeah, thank you
comment
very
and
much.
questions.
Yes, I listened to you very keenly. And at the end of the day, what I was telling myself as you were talking, I said, this thing is like it's now a social problem. It's more of social than medical. Now, the thing has to do with agreement. It has to do with agreement. A lot of factors have to be put in place. The hospital policy have to be considered. Then the what they call it, the patient stroke, the relative, you know, opinion also need to be considered. Then your own very opinion, your own opinion as a therapist, very, very important to consider. So there are these three factors you need to consider. In some facilities, they may not have enough bed space. And what they do is to discharge their patient as early as possible so that other patients, can access the hospital. So you need to consider that. Then, if there is sufficient bed, the hospital may not frown at it because after all, they need the money. Then you consider also the patient or relative. Now, they want to stay. Some other patients or relative want you to discharge them. So if this individual is the one that is saying, please, my place is far, I can't be going and coming. Can you just let us still be for another 1 week? It's an agreement. You consider that. Then you consider yourself. Are you comfortable with it? The patient has been discharged, but you are the only one keeping the patient. Or the patient has not been discharged because you have not given your assent, because we need to also consider that. In some institutions, they will not discharge until physiotherapy give an assent that they are fit to go home. So it's still waiting. I don't know how your institution works. As your institution discharge the patient before you continue to see, if they have discharged the patient and you are seeing there's a risk, there's a medical legal implication. If anything happens, The patient has been discharged. Why are you still keeping the patient? So you have to consider medical legal implications of that. But if the patient has not been discharged because the consultant has not received your own opinion that you are satisfied, the patient can go home. And for that reason, they have not discharged. Then you can still keep the patient. So a lot of factors you need to consider. So that's how I'm going to respond to that. Thank you very much.
Thank you.
Yeah.
Thank you, sir.
All right.
Mm.
So no other question, no other comments. I think I am done. So thank you very, very much, the moderator. Over to you, ma.
Thank you. Thank you very much, sir.
Yes.
We're very grateful for today's workshop, and we've learned a lot from the workshop. The afternoon session with Professor Bashir Bello will start by 1:30, so we can go on a short break now. This is about 12:50. So in the next 40 minutes, please kindly return for Professor Bashir's aspects. That's 1:30, so we can continue with the workshop for today. Thank you so much. Grateful. Thank you, sir.
Thank you, ma. Thank you very much, ma.
Please, can someone help answer me? Please, when are we coming back?
We are coming back. Dr. Suleiman, good afternoon, sir.
Good afternoon, sir.
We are coming back by 1:30.
Okay, thank you very much.
Sir? Yes. Yeah. I try. So I'm trying to relocate, but I've not been given the opportunity. Don't have this. No problem now. Good afternoon.
Good afternoon, all. Now it's about 1:31, and it's time for the second aspect of our workshop. Professor Bashir Bello will be taking, and Professor Bashir Bello is here with us for the workshop, and it would have the floor now. You can kindly unmute, sir, and continue the workshop, sir.
Hello, good afternoon. Hello, can you
Good
hear
afternoon.
me?
Good afternoon, sir. We can hear you, sir.
Oh, great. I just saw we have like 50% of the participants. Shall we commence, or we need to give another 5 minutes?
We can comment, sir. They will join in, sir.
All right. So let me share my slide. Is my slide clear? Can we see it? Can we see the slide, please?
Yes, sir, we can see the
Yes.
slide.
Yes.
Okay, good afternoon, everybody. Well, welcome back to the second session of the workshop for today. My name is Bashir Bello. I'm from Bayero University, Kano. So I'll be taking us through the second aspect of the class. I put on my video. If you have not seen me before, that's my page. And I'm just going to put it up so that we can concentrate and move. Is that good enough?
Yes, sir.
Thank you. All right. This aspect is about writing a discharge report, what really matters. So Dr. Fine early this morning has taken us a lot of information, so much he has dealt with, and I'm just going to give us a wrap up. And then practicalities, how do we have to use the discharge report? So as a way of beginning our workshop objective, I hope the slide is changing, please. You see the new slide I put up? Are you seeing it?
Yes, sir.
Yes. So the workshop objectives include, we have to explain to ourselves what are the essentials that are needed in our discharge report. I have listened to Dr. Fine. He has mentioned so many about it. So we're going to look at it again as a summary and wrap up. And of course, we want to describe the essential components of the complete discharge report. And then the last thing is for us to be able to strengthen our skills in writing a clear, structured, and professional discharge report. Now, we all know that from what we have learned this morning, why discharge report matters is that number one, it ensures continuity of care because it helps to guide the next healthcare provider. If you discharge your patient, it's either he goes back home, the family continue to do the care, or he himself continues the care, until he's able to integrate himself back into the society. Now, it's possible another healthcare provider will need to continue the care, maybe in terms of a different aspect of the care or whatever. But he needed information to know what has this person been going on before now, what had happened to him, what interventions were given, and then what are the information is bringing back to this person. So these are all very, very important information we needed to clarify. Of course, the discharge report will help us to demonstrate our clinical accountability. Here, it tells you your ability to document everything you have done to this patient so that when someone else picks up the file or somebody picks up your discharge summary, it has a very good and clear picture of what it's all about concerning the case of the individual. So your discharge report should be able to show the documenting interventions and outcomes clearly. And of course, this can even serve as legal records. Imagine the healthcare provider, that is the HMO, the health management officers or organizations, are saying our client came to you and then you gave a bill of ABCD, and we don't believe all these have been done. Sometimes the clients will say, no, I did not receive this or receive that. So as a legal document, a complete documentation of your discharge report is going to capture all those things. And then, of course, it will also serve as ethical record. What are the interventions that you have had? Are they really ethical? Were you able to protect the patient, confidentiality, the rights of this patient and everything, as long as they are both documented so they can serve to guide or to protect both the patient as well as the healthcare provider. Now, in writing this discharge report, there are some common pitfalls that some people fall in, and we really do not know. So it's very vital we demonstrate some of these common pitfalls. Like sometimes you report your discharge report may omit the patient identifier. That is, you only wrote the name of the patient, saying, for instance, Jacob, Emmanuel Jacob, and you can have millions of Emmanuel Jacobs elsewhere, but you didn't capture maybe the hospital number. So this will create a lot of confusion, and of course, you will risk even losing the information of that patient. So we must have to avoid all that. Of course, sometimes we use so many language because we want to show it coming from a doctor. So you're likely going to use some medical jargons or big language that makes the report very unclear, especially to the patient or to other professional colleagues. So these are things we must learn at the end of today to try to avoid when we're writing our discharge report. Of course, another time is we have poorly structured or incomplete report. Listening to the earlier speaker, my colleague has mentioned some structures, and of course, I'm also going to demonstrate some clear structure we should also follow when we're writing our discharge report. Of course, if you don't write it in a structured manner, it's likely going to compromise your patient safety, and of course, it's going to distort the teamwork from other healthcare providers to follow up. So in general, our workshop agenda is going to explore the core component of a good discharge report. That's the first thing we want this workshop to be able to demonstrate to us. What are those core components that we must see if we say this is a good discharge report? Of course, we should be able to know the national and international standard and guideline of discharging patients. I want us to know what is our MRTB SOP, that is, scope of practice in trying to discharge your patient. Most of us do not know them, or most of us do not follow them. So we need to know that these things are there internationally and internationally, and then we need to appraise ourselves with those information, because that is what entails the global best practice. So you must know them. Of course, we're going to practice it at the end of today. As we long up in this our workshop, we're going to practice the practical writing skills for clarity and accuracy. So we're going to have some groups at the end of the day, and from those groups, one person will be the group leader or secretary who is going to present for their group what they have written as a discharge report. So, of course, we're going to be working through many groups, maybe the orthopedic group, neurological group. So all these are cases. We're going to talk about that. And at the end, we will conduct a peer review and feedback sessions. That is, after each group presents, we will see what are the problems ourselves. So we critique all the presentations, and then we give ourselves feedback. We show ourselves what are the strategies or what are the common errors, and then what are the strategies we can use to improve our discharge writing process. At the end of the day, we're going to have our key message, and we reflect and see how we're going to move ahead from this moment in terms of discharging our patient. So, ladies and gentlemen, if you are following and it's clear, I think I just see a thumb up. I can just move. Is it okay? Can we go ahead? Okay, yes, thank you very much. Now, I said a well-written discharge report is built from essential elements. And each of these elements, they add to the accuracy, completeness, and usefulness of this report. Whenever we have a missing or weak component, it reduces the clinical value of that report. So we must know that there are elements that you must have in your discharge report. Let me ask us at this juncture, do we really discharge our patient from physiotherapy? Yes, please, colleagues, you can open your mic. let me have your honest opinion. We have your honest opinion. Do we discharge our
Sometimes,
patients?
sir.
We do
let me
sometimes.
see. Who is speaking? Tunde Jimo. Yes. You discharge your patient?
Yes, sir, we do sometimes.
Is that Mr. Tunde? Let me listen. Someone else, if Tunde is not listening. Yes.
Sometimes, sir.
So it means it's not a static thing in your system to start your patient and discharge them. So he said sometimes. Oh, beautiful.
Of course,
I want us to be very realistic and practicable with our information. So if you do at some times, how do you do it? How do you discharge your patient? Please, let's hear you, Mr. Jimo. Are you with us?
Hello, sir. Can I speak, sir?
Yes, speak up. Just come close to your mic.
Okay, sir. So when I'm about to discharge my patient, the first thing I do is to discuss with the patient, remind him of my assessment in the first visit.
Excuse me, is that Tunde or Suleiman? Who is speaking?
No, it's Suleiman, sir. Suleiman, sir.
Okay,
It's Suleiman, sir. Suleiman, sir.
Mr. Tunde was given the floor to speak. Hold on, you speak after him. Thank you.
Okay, sir.
Yes. Yes, Tunde Jimo, please, sir, can you go ahead?
Sir?
You need to be very close to your microphone. We're hearing you far away.
Sir, should I speak?
Not you yet. I'm still giving Mr. Jimo the floor. Just for 10 to 30 seconds. Are you there? Okay, Mr. Suleiman, can you come up? If you discharge your patient, how do you do it? Hello, can you hear me?
Yes, we can.
Hello, Suleiman, are you there? Okay, Osigbe, go ahead.
I think I will discharge the patient once.
No, have you discharged a patient from your facility before?
Yes, sir, I did one.
You did
it was
one?
a patient with a
okay,
stroke
I
patient
would just
who
want you
was
to just give us a summary. What did you do? How did you discharge the patient?
Actually, I make sure the patient's dexterity was okay, and
what do you mean
because
by
he was
the
a
patient is
Liberian.
okay? What do you mean by the patient is okay?
I did an outcome assessment for his function and his ability to participate in the society, and he showed a very incredible result. And because he was a Liberian in university, so I wanted to see if he can actually do those fine movements of carrying books in his library where he works. So, and he was able to, and we found that the BP, I mean, the vitals were stabilizing. They were going below 120. So he was getting to 50-year-old, a 50-year-old man. So at that time, we told him that he's going to be coming once in 2 weeks. After some time, after like 4 sessions, he's going to be coming once in 2 months. And before we know, we just say, okay, it's good to go. You can only visit us to complain from time to time. So it was not a formal write-up.
This is where I'm going to. So there was no formal documentation that was put in his file, neither was it handed over to the patient. Was there anything like that?
Yes, sir, there was no formal write-up.
Okay, thank you very much. That's the honest discussion. But do any person have a different experience in discharging his or her patient? Any other person? Please feel free to talk. It's an interactive session, so we don't have to be rigid. Okay. Since we don't have any other different opinion, it means we agree that in physiotherapy or in any of our rehabilitation, because I'm expecting colleagues from occupational therapy, speech therapy, and audiology all to be in this platform. Are we there? Do I have any occupational therapists participating today?
So I think this module is for physiotherapy only, sir.
Oh, this is for physiotherapy only. Okay, that
Yes,
makes
sir.
it easier. Beautiful. All right. So I am assuming that since nobody is giving us a different opinion on their discharge modality in his or her clinic, maybe private or public hospitals, it means most physiotherapists do not have a formal way of discharging their patients. Are we all aligned to this? Do we agree this is what we do? You can drop comments if you don't want to speak out. Yes. Right. I think we agree that most of us here are just the same way we have agreed that's what physiotherapists or most of us we do, that we do not really have we don't have any formal way of discharging our patients, right? So I was trying to come up with an overview of those components that are needed in a well-written discharge report. And I said each section of these elements, they add to the accuracy, the completeness, and usefulness of the report. And any missing or weak components will reduce the clinical value and applicability of the discharge report. So the first thing we want to see in our discharge report is what you call the patient identifiers. Like when the last speaker, Sigmame, was speaking up about his experience of discharging a Liberian patient, he started by not telling us the name. While he was speaking, he remembered he needed to tell us the age. He went back, so back and forth. So it must have a design and a pattern in which you will present your discharge report. And the first aspect of that essential component is what you call the patient identifier, because you need to include the full name of the patient, the age of the patient, the gender of the patient, as well as the hospital or record number of that patient. Number two, you need to give us the information about, did you admit the patient? At least when did the patient start visiting, or when did the patient came into the hospital for his ailment? And then on what date are you discharging this patient? So all this must be clear in the medical record. Okay? This is to ensure that the report cannot be confused with another patient's own. So please, the patient identifiers are the first thing we must put together when we're trying to write a discharge report. So because you know that this is whom you're talking about. Now there is the context of care. It is, why was the patient in your clinic or in your hospital? Okay? For instance, you need to specify the reason why the patient was referred. Did he get a referral from surgery department? Is it from a neurology department, from internal medicine? The events, when you document this patient was sent from surgery department, it's already given whoever is reading that discharge report, where this patient came from and the likely problems you would have presented with. Of course, you should be able to indicate the setting where the patient is coming from, or where he had the care was provided. Was it based on an outpatient care, or is it an inpatient or from the ICU? So all these will give a context of what kind of care the patient had got or had before now. Now, it helps you to think wider and broader the care pathway this patient had gone through. So it will give you more information about what he has underwent or undergone. So you also need to talk about the diagnosis and then the presenting complaint. What diagnosis has been made for this patient? For instance, you should be able to state the primary diagnosis clearly and accurately. A diagnosis cannot be saying, the patient presented with pain in the shoulder. So that is just a complaint. That is not a diagnosis. A diagnosis should be able to tell us what exactly the patient had after evaluation and examination of that shoulder. So for instance, we say the patient had an acromioclavicular bursitis. The bursa there got inflamed, or you talk about the patient presented with a frozen shoulder, so many diagnoses that could be made clearly on the patient's folder. Of course, we should be able to describe the complaints and the functional limitations the patient presented with. Okay, it is pain in the shoulder, inability to wear her brassiere, inability to lace the shoe, inability to put on the trousers, and so on and so forth. So those functional limitations must be captured in that report. We should be able to list other comorbidities that may affect rehabilitation. For instance, the patient was a known hypertensive patient or has been diabetic for this amount of period, and or the patient had a previous surgery in the neck or whatever. So all these will tell you what you should be careful and aware of. And of course, in that report, we must have what you call ability to check for errors in the documentation. So that when you are writing all these, what we call the presenting complaint, we should try to avoid vague terms. Like when you say the patient had back pain, for us as physiotherapists, what do you mean? Is it an upper back pain or a lower back pain? So we want to know, is it a chronic lower back pain you had with the patient from the beginning or an acute back pain? So please, when you write things like back pain only, it reduces the clarity of what the patient came with. So we should try to avoid such information. And of course, if you omit comorbidities, it will create gap in the patient file. You didn't mention that the patient is a known hypertensive patient, and then he presented with neck pain, and maybe the next person who is coming to continue the care will just go ahead to do a neck traction that may lead to a more disastrous outcome. So it will have been nice you give the comorbidities a patient is presenting with. And of course, we say you should not overgeneralize the statement, because if you do that, you may mislead the future providers. Or what is an overgeneralized statement? The patient had weakness of all limbs. Now, not generalized. When you say weakness, are we talking about malaise? Are you talking about paralysis? Are you talking about paralysis? So all this is an overgeneralized information that will mislead someone in the future. I think I missed the treatment goal. Yes, that's the point I want us to talk about. Now, your treatment goals should be embedded inside the discharge report. That is, the treatment the patient has had while he was under your care. And we say those treatment goals should have been SMART. That is, you must have specific goals that are measurable, achievable, they're relevant, and they're time bound. Like when I asked Mr. Osibome when he started, he said his patient was okay. What do you mean by being okay? You know, we started with the patient who was having inability to lift his limb in a gravity assisted position, and we presented with power 3 and all that. So we created, our goal is that we want the patient to be able to move from power 3 to 5. We want the patient to be able to ambulate without support. So all these are clear goals that are relevant and achievable for those patients. And then you have to add your time bound. Want him to do this for the next 2 weeks, next 4 weeks, next 6 weeks. So all this should be your goals that you have presented in that case file. So if you're saying the patient have walked from this point to that point, so those things must be measurable, achievable, relevant, and time bound. Of course, the goals must reflect both physiotherapy objective as well as the patient need. So it should not be just about the physiotherapy trying to move the power from 3 to 5. It must also consume what does the patient want. I'm sure he does not want 3 to 5. All he wants is for him to be able to walk without or independently. So you must add all those information in your discharge report. So your ability to link the goals to functional outcomes shows that, yes, the patient really benefited. So even if you are submitting the discharge report to a third party, like an insurance person, institution, that's all the information they want to capture from the patient that came through their service. So in the same vein, you should be able to itemize and outline the physiotherapy techniques and modalities that were used in managing the patients while they were in your institutions, including the frequency of treatment, the duration of the treatment, and intensity. Like I said, your discharge report is supposed to be both a legal and ethical document. So for any reason, if you have documented all this, there will be no room for any criticism. Of course, we should provide the rationale why those interventions were used and not others. Okay, so you should be able to mention that in your report. Of course, we should also be able to itemize the use of validated outcome measures. I queried Osibeme the other time when he said his patient became okay. What do you mean by okay? So you just said the patient presented with pain intensity that was bothersome, and it was measured to be 7/10, for instance. And then after those sessions of treatment, our patient VAS score had moved to 0/10. You know, the functional ability or limitation was measured using the Osprey Disability Index, and it was at the beginning about 60%, and now we have reduced it to 25%. So all that is something you will measure. Of course, the WOMAC or the functional impairment movement, all these can be measured. So the outcome should be validated and reliable. And of course, we should have the objectivity of reporting that outcome. Because if I say my patient pain has reduced and is complaining of no pain, you have not used a numerical outcome to measure the pain. So you must make sure there's a numerical outcome. If you write a discharge report and say the patient became fine, his pain had gone down, so we don't know what you're talking about. Most third-party insurance may not pay for such type of services. Okay, so it helps us to know the benchmark of progress against the discharge goal. So if this patient, we want to reduce his pain from 7 to 2, for instance, before we discharge, then the patient we have assessed is now 7 is 0. You know, there is every room for discharge because we have met the benchmark for discharge that we have written in our goals before the treatment started. Of course, we should also make sure that we provide a clear recommendation after the healthcare services in the institution, the patient is going back home. What are the information you want the patient to know and practice at home? It can be advised in terms of sleeping, lying down, standing up, walking. There could also be some clear exercise program. So all those must be tailored to patient understanding and the need, what the patient needs to achieve from it. If any of those self-care management will include any precautions or restrictions, you must have to tell the patient to ensure his or her safety. And of course, that discharge summary report we are writing, we should be able to suggest, are we referring for further follow-up care or not? So if the patient is for us to see him in the next 8 weeks or 12 weeks, we should be able to see that it is documented in that discharge report. Ladies and gentlemen, I hope I'm not too fast. Are we on the same frequency? Can we continue in the same way? All right. I assume it's okay if I have not had any response.
Go ahead, please.
Okay. So I talk about closing the relationship. Now your patient is going back home. Does it mean you have nothing to do with the patient again? No. You should be able to indicate clearly in that discharge report that the patient is being discharged from physiotherapy care. Why? You must state the reasons for the discharge. For one, the treatment goals have been met, or the patient have plateaued, that is, it's peaked in progress. So there will just be need for a transfer or referral on another side. For instance, you can refer your spinal cord, sorry, not spinal cord injured, we can refer a hemiplegic patient, to either an occupational therapist saying the patient has plateaued or he has peaked in any kind of strength, coordination, or balance treatment. Therefore, you want the patient to be able to go back to ability to do their chores or meet the occupational needs from the occupational therapist, and therefore you are referring the patient to such a facility or care. So the reason for discharge, so that somebody says, why are you seeing this stroke patient? And you are not saying you are discharging him. Of course, stroke patient could be discharged based on the goals you want to meet. I used to know one of my boss that will tell you for stroke patient, they have this, is it 999 peak, goal of duration of progression, that your patient picks up the first 9 days, then the first 9 weeks, then another first 9 months. The moment is 9 months, your patient has plateaued. So all these are something we should put into cognizance when we are reporting our discharge, right? And of course, we should be able to reinforce our closure of the therapeutic relationship, that we are going home. We just know that these are the things we've been able to do for you. And then we hope you should be able to keep in touch. If there is any way we could help you, you're always welcome back. So these are how we should close the relationship, not following up to either gain a sympathy, or because the problem under closing the relationship is some of us are very, very not careful when it comes to interacting with your patient. A male patient seeing a female patient, or a female patient therapist seeing a male patient, you can be so close in your relationship that it begins to sense as if there is an emotional attachment in it. So you must be clear. There must be a clear line between professional and then a non-professional way of dealing with patients. So you must close the relationship professionally, right? Some of us could even have relationship when it has to do with both gender, male to male, and then you realize that you have something that you want to achieve from that patient, and you wouldn't want to close the relationship. Even the patient is okay. So there are rooms you're going to fault yourself and find yourself to blame at the end of the day. So you must close the relationship by discharging your patient professionally. So let's look at the checklist that we should see in as a component of what we call a good discharge report or form. Like I mentioned, the first thing you need to see in the component is the patient information or identifiers. You want to know who is this patient we're talking about, when did he come in, when is he going out, what is the problem, and all that. You need to see that. So you need the patient identifier. Then you need to know the primary diagnosis as well as the presenting complaint when the patient presented to your facility. Of course, you need to know what are the treatment goals. What was it that was designed to treat this patient? And of course, the interventions that were provided. So you need to put them together inside as one of the components in the checklist. You also need to note the patient progress as well as the outcomes that you have used to measure the progress. So you make sure that all those are in your discharge form. And at the end of the day, you should recommend how the care should continue outside your facility. Of course, we should have the statement of discharge and closure. This is the last point. We're dealing with the patient. We've moved the patient back home because it's ABC, or we have moved to another facility due to 1, 2, 3. So these are the components of check them. I will try to see the framework. Okay, there's a framework that you should use in your patient discharge reporting. Let's look at the framework. We call it the S-bar framework. S-bar. So the S-bar framework in patient discharge reporting include the S means the situation of this patient, the background of the patient, assessment of the patient, as well as recommendation you're giving the patient. So this is the S-bar framework. I said the S-bar framework provides a clear, concise, and standardized approach to communicating discharge information. The S-bar ensures that critical details are transferred accurately to the next healthcare provider or caregiver. So this is why we must use this framework when we're trying to deal with our patient discharge. As I said, the situation here is we should be able to identify the patient by name, age, as well as hospital number or the record number. So the patient is Mr. Bello Bashir, is 47 years old. He presented with an acute low back pain. So you've been able to tell us the situation of that patient. And of course, you should be able to state the current clinical issue, okay? That we have treated this patient for 10 sessions, and the pain he presented with at 8/10, it's now 0/10, and therefore we want the patient to be discharged from our facility. So this is an example of what I wrote here. I said, Malam Musa, a 62-year-old post-stroke patient, is being discharged after completing inpatient physiotherapy. Now, when I said inpatient physiotherapy, is this example accurate for what I'm talking about, the situation of Malam Musa or Mr. Musa? Colleagues, please, I want us to speak up so that we're able to discuss. Yes, please. Yes, any person? This example I gave, Mr. Musa, a 62-year-old post-stroke patient, is being discharged after completing inpatient physiotherapy. Is it a good example of a situation of Mr. Musa?
Yeah, I think so, sir. You talked about his name, his age, and what exactly happened to him. And then you also spoke about the type of treatment he received, inpatients or outpatients. So I think it talks about him.
Okay, thank you so much. So somebody said this situation, so number one, we've been able to identify Mr. Musa. Okay. Please, can any person see what are any issue in terms of the situation of Mr. Musa? I want us to identify. There are some 2-3 issues I left there. Would somebody please pick them out? What are the issues?
The medical number and the
Beautiful.
reason why we charged.
Yes, medical number is missing. What else?
The reason why I was discharged, like did you say what?
No, I mentioned that after completing inpatient.
Okay, after completing. Okay.
There are issues. I want us to look at it and identify what are those issues. Yes, please, colleagues, let's do this.
So I think the current clinical issue is not stated.
He said the current clinical issue is not stated. Do we agree? Yes, I did not state the current clinical issue. Definitely. There's one more important thing that is missing. Very important. Yes. Okay, somebody is saying they are not getting the question.
How many hours of, okay.
Yes, how many hours of the intervention?
So how many, yes, how many hours of intervention has he received? Or how many for the duration?
Do you think I need that for me to present the situation? Don't forget S-bar. We're only dealing with the S. We're the BAR. Now, ladies and gentlemen, what I wanted you to pay attention is, I said the first thing is you should identify the patient by their names. When I say Mr. Musa, am I giving the full name of this patient?
Yes.
No, sir, the surname is not there.
So
Anybody
the full name of this patient is not there. The next one is the age. Of course, I gave the age. And the last one is the medical record number. You get the point now? So, because this can be any kind of Mr. Musa. We get it? So please, we must make sure that we drop those information clearly in the discharge reports. Okay. Moving forward, the B in S-bar is the background. We should be able to know what is the background information about Malam Musa or Mr. Musa. I said we should be able to provide relevant medical history, the hospital course, that is how he has been from the hospital to now we want to discharge. We should be able to have a summarized diagnosis, comorbidities, and the physiotherapy intervention. Here, I also gave an example. I said he was admitted 3 weeks ago with left-sided hemiplegia. He has a history of hypertension and diabetes. His physiotherapy intervention included mobility training, balance exercises, and ADL practice. Have I given a good background for these patients? Is this background enough for you? As somebody who wants to take the next care?
No, sir. I think you've omitted like the proper history actually. Like what was the muscle power or something where you started from? I mean, when you started, what's the muscle power now? Such kind of history I think we're missing. So we don't have proper relevant medical history.
Yes, yes. We said we want a relevant medical history, right? So I gave you an information that he was admitted 3 weeks ago with left hemiplegia. But I didn't tell you even when he was admitted, because the next information is the hospital call. On what power did he come? I said hemiplegia. Your hemiplegia can be power 0, 1, 2, or 3. Is that not correct?
Yes, sir.
So you can see I have left some vital information that you have wanted to know. When he came into my hospital, was he at power 0? Now that I'm discharging him, what am I giving him? What is the cause? Where he is now, he's not there. I don't know if you are getting my point here. Hello?
Yes,
Are
we
we
are.
together? I want us to scrutinize the example I put there.
Yes, we are
With
getting
you,
your
sir.
point, sir.
So you can see that his hospital cause was also not mentioned there, right? Now, did I mention his diagnosis? I mentioned Mr. Musa's diagnosis.
No.
So you mentioned the medical diagnosis, not the physical diagnosis.
So what would you want to have as a diagnosis for this patient?
I would want to know if it was a CVA, was it ischemic, was it things like that? Do you get where exactly was the cause of the hemiplegia?
Now, because the diagnosis for this patient, is it supposed to be hemiplegia or is it supposed to be a stroke? What is the diagnosis?
It depends on what caused the
No, with what I have
hemiplegia.
here. With what I have here. I said he was admitted 3 weeks ago with left hemiplegia. Do I have a diagnosis here?
No, sir, you don't have a diagnosis.
So what's supposed to be the diagnosis?
CVA, stroke.
That's what the young lady was speaking earlier, talking about. The speaker earlier said we're supposed to know, is it is it a CVA, so those things. What kind of cardiovascular accident did the patient have? Because it also tells you the kind of prognosis you should expect. Imagine your patient having what do you call it? The stroke that has to come with resolution of the blood vessels. What do you call it? I'm not in neuro, but when a patient have this stroke that comes with busting aneurysm, it resolves faster. What do you call it?
Hemorrhagic stroke.
Hemorrhagic. Thank you very much. That was hemorrhagic stroke. Those are the strokes that resolve faster than when you have the one with ischemic. Okay, that there is maybe what do you call this plaque? Okay, so now all these are the kind of stroke. You want to know this patient had a stroke. Okay, now he was admitted 3 weeks ago with left hemiplegia. It's possible this stroke had been there maybe a week before he was admitted again for hemiplegia in your place. He was supposed to be written. The patient was diagnosed of stroke on which day? How long? You need to know the stroke and the time, not when he was admitted only. All right. So do we also have comorbidities presented? Have I presented comorbidities?
Yes.
Yes.
I
Hypertension and
said he's
diabetes.
hypertensive, he's known to be hypertensive and diabetic before now, right? So now, did I present the physiotherapy interventions?
Yes.
Yes, I did. When I say mobility training, you guys know we'll have to do muscle strengthening, muscle, what do you call it? Where are the stroke guys? Where are the people in neuro? You guys are not speaking up for yourselves. I'm going to be sending you different things. As Osigbeme, I'm in this meeting, you're giving me a phone call. Where is he? Is he there? Thank you. Okay. So This is another example of a background I'm talking about. You should have in your SBAP framework that you should be able to provide this relevant medical history, the hospital course, how he has been from when he came in and when he's going out. You should be able to have the summarized diagnosis, the comorbidities, as well as your physiotherapy intervention. Now let's look at the A, which is all about assessment. That means you should be able to describe the patient's current functional status. Somebody was talking about this earlier when I said the S is only the situation. So this is where you talk about the current functional status of the patient. So you have assessed him now, this is what is in now. Of course, you should be able to highlight the progress he has made and any ongoing impairment. Does he still have something remaining or not? So I put an example here too. I said at discharge, Malamusa can now walk 20 meters with a quadricep cane. He could manage transfer independently from bed to chair, from chair to bed, or to the WC, and so on and so forth. But of course, he still requires minimal assistance for staircase climbing. Ladies and gentlemen, is this assessment good enough? Can we pick up some issues? Is there anyone that can pick up any issue here? Yes, please. Go ahead. Are you speaking with us or your phone is just open and you're not aware?
Well, for me, the progress made was not really highlighted. The patient's current functional status is there, but the progress made was not exactly highlighted. Then ongoing impairment, I think that's still that the patient requires minimal assistance for stair climbing.
But we've been able to highlight that the patient can now manage transfers independently. Is that not talking about progress he has made? Do you get the point?
Yes, I do, but we don't know where the patient is coming from, whether the patient could manage it before or not at all.
Yeah, at this point of A in the SBAP framework, we don't want you to think about where it's coming from because we have highlighted where you should talk about where it's coming from in the background. Okay? At the assessment point of the framework, we want you to just describe the patient's current functional status.
Okay.
I hope that's clear. Yes.
Yes.
Okay, thank you so much. Now, can we make forward? We're taking the last R, which is recommendation. I really want all of us to hold the framework at the back of our minds. Let's just keep it there. When we're talking about the S bar, the S bar, the S for the situation. Please, can Mr. Tunde, do any person have his number to tell him to just mute? The guy is not with us and he has been disturbing. Tunde and Ridwan, please mute yourselves. Thank you. So the last part of the SBRA is R, which is the recommendation that we should be able to provide a specific instruction for ongoing care and follow up. That your discharge should be able to talk about that this person is being discharged and is to see the physiotherapist in 6 weeks, in 8 weeks. So there must be a very clear instruction which is specific. Sorry, the anchor, can you please mute them from your side? Yes, please kindly check if you could help me mute them. Thank you. They are not really paying attention here. You can see they don't even know that we're calling their names. Good. Thank you. So I said we should include some home exercise programs, safety measures or precautions, and then we should talk about the referrals. Is there anywhere we want the patient to visit? Do you need them to go to the occupational therapist? Do you need them to go to the speech therapist? Or do you need them to see the neurosurgeon again? or the neurologist. So you should please create information for any home exercise program. This is where Dr. Fine was speaking about the self-management earlier today. So if you want the patient to go through some home exercise program, it means you should be able to teach them the self-management program. Protocols, it means the patient should be able to demonstrate it to you, must have practiced it, and you have understood that the patient know how to do those things before you ask them to go home and be doing it. Please, if there are any timelines you need them to do, all those things need to be clearly stated. So an example here I also point out is, I said, the patient is said to continue daily home exercise program for mobility and balance. You can see this is very clear. We also ask the patient to avoid uneven terrain without supervision. And then we also refer the patient to continue outpatient physiotherapy twice weekly, that we are going to reassess the patient in 4 weeks' time. So if you look at this example, did it give you all what you need to have in the recommendation? Please, let's look at it. Do we have all what we need for the arm in the SBAR framework? Let's quickly look at it. Yes, do any person see something that is missing in the recommendation? Don't forget, I say your recommendation should be able to provide. Mrs. Tolu, you guys, can you just remove them so that they can come back in intentionally? Really bothering me here. If you can call them.
Tosin Popola, please kindly mute your mic. Host, please kindly mute Tosin Popola. Is disturbing the class.
Let's look at the recommendation R. The example I gave. Is there any issue that we think is left out? Are we comfortable with the recommendation? Because the recommendation I said to provide clear instructions for the ongoing care and then the follow-up. So we should be able to include some home exercise programs if there are safety measures or precautions, if there are referrals or timelines you want the patient to know about, should be put on our discharge summary notes or report. And I said an example is the patient will continue daily home exercise program for mobility and balance. We have asked the patient to avoid uneven terrain without supervision. We refer that the patient should continue on outpatient basis for physiotherapy twice weekly. We have mentioned we are coming to reassess the patient in 4 weeks' time. Is this R intact or something is missing?
I think it's intact.
Is intact. Thank you very much. So we just look at the last line is, why do we think the S-bar is important? Why do we have to use it? Because I want us to really see the need for it. If you follow the S-bar, you will see that you have a structured and standardized report. Do we have it or not?
Yes, we do.
We do have it. Thank you. And you see that it reduces omissions and miscommunications. Everything you're putting there will be very clear to the patients, to other healthcare providers. So there will be no reason for miscommunication or omitting something vital in the discharge. Of course, it enhances the patient safety and continuity of care. Like when you look at the recommendations, you have already told the patient, even though when you do home exercises, this should be done based on that goal of you want him to learn how to balance and coordinate. And then, of course, you should avoid that. All these are patient safety and precautions we have mentioned. Of course, it saves you time, not just only you, for both discharging therapists and, of course, the person that will be receiving the patient as the next provider. So these are the beauty of the SBAR. So let's try to use the SBAR for some practical scenarios. Let's see. I said, for example, if I want to use this, I talk about the S, I'll just be saying I want to identify the patient and reason for discharge. I will include the patient's name, age, and presenting issue. Example, I said Mr. Ibrahim, a 50-year-old man, was admitted with lymphatics and is being discharged after 10 sessions of physiotherapy. That's my S. I've quickly put it down. I said the background is that I provided the clinical history and the treatment course, what happened to him, he fell down, he had this, and all that. So eventually might be, I should be able to summarize some diagnosis, comorbidities, and physiotherapy interventions. At this point, I will now try to see how will I assess it. I will present his current functional status and progress. I will include objective outcomes and the remaining limitations he has. Example, I said Malam Ibrahim can now walk 100 meters with a cane. Pain is reduced from 7/10 to 2/10. He now climbs, but still is having difficulty in staircase climbing. So all these are presented his assessment, And then I will recommend that the next step for follow-up care. I don't need to keep Malam Ibrahim in my place. So I said it should include some home program, and then what are the precautions you should be careful with, and who am I referring him to, and then the timelines. For example, I said I would ask him to continue core strengthening, avoid heavy lifting, and then we review him in 3 weeks. This is just a practical way of using the framework. Now, every one of us can have a type of this form designed in his or her clinic. Here is the patient information I've talked about, everything you need to know. Then we talk about the hospital, the primary diagnosis, what is the patient presenting with, and how long he stayed in the hospital and what he had, what are the treatment, the duration of the treatment, and is there anything you want somebody to note in his treatment, okay? If it has to do with medications, you need to know what are the medication is being discharged with in terms of frequency of that medication or exercise or whatever therapy you are giving, the duration and all that. Of course, you also have to give the discharge instruction and let the patient know these are what you need him to do. When is he following you up? In which department and which provider? Of course, you need to sign your name as the therapist or physician who is discharging the patient, your phone number. And of course, you need to get the emergency contact phone number of that patient you are discharging. So this is the small form that any person can just create and use to document your SBR. Okay, so far so good. The framework I have been able to put to us in a nutshell, and I expected moving forward from here, we should be able to demonstrate the use of this form. Please, I want us to make a group in this list. We're about 70, over 70. Now, I really just want us to divide ourselves maybe into 4 groups. What are the 4 major specialty of physiotherapy we have? So please just agree amongst yourself. You're going to take 4 groups. Please, who can state which group we should go? I know there must be orthopedics and sports. Sorry, orthopedics and sports is one group. There should be neurophysiotherapy group, pediatric physiotherapy. Which other one should we put as the major 4? Yes, which one? Cardio, women's health.
Cardiopulmonary.
What?
Cardio.
Cardio. Okay, the cardio people have taken the 4th one. Do we stop at 4 or we want to share it into 10, 10, 10? We need 7. Yes. Okay. maybe we're going to keep it at 7, right? Okay, so at 5, so we'll be seeing what we need as we move along. So I brought this as part of the Nigerian standard of healthcare because we need to know in our facility. Do anybody know the scope of practice of MRTB or NSP? Do anybody have an idea that according to the scope of practice of physiotherapy in Nigeria, this is what we must do to discharge our patient? This is how we must discharge our patient. Has anybody read any document or report from MRTB and NSP? Hello? We say we don't have a document. Because if you don't have a document, the MRTB will not have put up this as part of their CPD. There is a document. There is a channel where we must learn how to discharge our patient. But the MRTB has identified that many of the therapists discharge their patient without any formal way of doing it. And that's the essence why this aspect must be part of the CPD that will be covered. I hope we are getting it now. So the MRTB and NSP, their scope of practice, say we must align our practice, that is, with formal way of discharging our patient. So the NSP scope of practice is presently being reviewed, and I'm happy I'm one of the members of that committee. And of course, I'm ensuring that our discharge report or discharge pattern must be captured vividly in that document. So, but I know that there are a lot of institutions where we work that has hospital policies of how to discharge. Because you see, Nigeria is a special breed on its own. The document in hospitals will capture only doctor discharging. Of course, I'm the physiotherapist, the patient is coming to me, I'm also treating him. And I'm the one to discharge. But the hospital policies will not capture that the physiotherapy has that mandate, has a mandate to discharge his patient and document the discharge. I could tell you there was a time a former practicing medical doctor had a stroke. This man's stroke was being managed by some of our senior physiotherapists, and then there was a family issue about the man where the wife was trying to divorce. I think it's a polygamous home, and the case got to the case was taken to the court of law. You will not believe, I'm sure if the therapist we are talking about is with me here, he will know that he was invited to the court. Because one of the accusations is that one of the wives said that she went to institute that the patient should be, that he has been discharged from physiotherapy. Because she never wanted him to continue his care. All she wanted was the patient to suffer and die, and then she inherits his properties. So it can be that crazy. So guys, you just need to understand that these things are very, very important things that we must learn how to make our documentation. When this young chap was called to the law, of course, the law doesn't want to listen to you. They want you to show documents. Okay? They want you to show documents. So please, we must learn that. Oh, sorry, please, I muted. Okay, so I said we should ensure that our national, we should ensure we follow, we are consistent in our practice with our national guidelines or scope of practice. Yes. So over internationally, you will see that our global bodies such as the World Physiotherapy Organization, the Charter Society of Physiotherapy, American Physiotherapy, Physical Therapy Association, all have complete standards on how to take in and then discharge your patient. So this is seen as benchmarking against international best practice. Because most of us, we go out, some of us go to the UK, we go somewhere, we practice. We must know all these things. So we must appreciate the Medical Rehabilitation Therapists Board for bringing this part as a compulsory CPD. Because we have not been doing this, I'm sure many of our colleagues do not see it as the necessity to register for this workshop because they feel, what do you want to learn in discharging your patient? So please, it's very, very vital because we need to remain and work based on the best global practice. Okay? I said, when you do that, your discharge pattern will ensure that you have a minimum benchmark against the international practice, and that will strengthen your local credibility that you're coming from a local side, but you already know about all this practice. And of course, it helps you to be able to harmonize your physiotherapy practice documentation worldwide. That is, you know that the way you're doing it is wherever you find yourself, that's how they are likely also going to be doing it. So we talk about some ethical considerations. When you do your discharge report properly, you're able to respect the patient confidentiality at all times. That is, all those information you know about the patient, you have to guide it. Like the patient we're talking about with stroke, you know, one of the wives came, were trying to find out from the therapist, who did this, who did that. He refused to say anything to her. Well, you didn't bring the patient to me, and I don't know you with the patient, and I'm sorry, I don't have any information I can give to you. It was only when the court called the therapist, then he went in with all his documentation, and he was able to present to the court what he knew about the patient. So, and I said, whenever you are writing your discharge summary or your discharge report, those reports must be very accurate and truthful because you don't know where it's going to get you. Don't write a patient has improved when you know that it has not yet improved, or your patient, you said his pain has moved from 7/10 to 2/10, where you know that the patient is still going through some considerable moderate pain of 5/10. So you just have to be accurate and truthful. Yes, I say our patient rights and dignity should guide our reporting. Don't think it's all about you. Your patient has a right and he may call for those documents. And I talked about the legal consideration. According to legal principle is that if it is not written, it means it was never done. So if you don't document all those discharge, it means you never discharge the patient. So you must document it. Because this report, like I mentioned earlier, they can serve as evidence in a legal way or for insurance cases. I've mentioned all this. So therefore, proper documentation is likely to protect both the patient as well as the physio. Now, of course, it also helps you in your multidisciplinary role. Imagine that a neurosurgeon is talking to you about a patient he claims he has discharged, and he feels you don't even understand the communication. But it is your right to now point out, how did you discharge this patient when he still has A, B, C, D? Why will you discharge this patient without all this? So the moment you're able to talk about the strength of your understanding about this discharge in a multidisciplinary role, it means, you know, your status, the confidence you have put in the team, and of course, the respect for your profession will be upheld. Okay? And then every person in the team is ready to collaborate with you in terms of those kind of patient management because they believe that your input will help to enhance the teamwork and the patient outcome. We must know that when you are writing a summary, a discharge summary or a discharge report, I mentioned that we should please use simple, precise language that everyone can understand. Please don't claim you are that medical doctor that want to write Jaga and you think you are doing something good. It's useless. Communication is about understanding. cannot understand what you have communicated is useless. Okay? We should avoid professional jargons that could confuse even those who are non-specialists. So please, you should write as if another clinician will read and act on it tomorrow. So if your writing is very bad, it will depict the person you are as well as the profession you are representing. Please protect our profession for us. That is all we have, and that is our pride. I said when you're trying to do this discharge report, you should be structured and then flow with it. We've given us the S bar that gives you a structure and a flow. You should use headings and subheadings to separate sections. You should follow a logical and chronological order from admission to discharge. And then your structure reports are faster to read and easier to use. So, for instance, I gave some before and after examples. When you're trying to talk about the patient, you say patient improved after therapy. That's a weak information. It can't be useful. It gets, if the patient improved, in what? So a strong way of writing that your patient improved on quadricep power from power 3 to 5 or 4. And then he has been able to walk now 50 meters using a cane. All these are specificity and there's objectivity that could add value. So I said we should also use validated tools like the ODI WOMAC in making our documenting scores that shows it is measurable. It shows progress, okay? This will strengthen the scientific credibility of that report. What it means here, you can even use those documentation for research purposes, all right? So there are some things you should not do, or we call them the do's and the don'ts. The first one, we want you to be concise. That's what you need to do. You should be concise, factual, and comprehensive. That is, you should be truthful. You should not hide information, but you should give it in a way that somebody can swallow it in 1 minute. Okay? Of course, we should be able to use measurable terms and structured section. And one thing we should not use, we should not be vague, we should not be subjective or judgmental in our statement. All right? So all these are our concerns when you are writing a discharge report. I believe in today's social media, you have seen when you have a medical report, it's been shared in many of our WhatsApp group and things like that. You know, you read something, you know, I can swear with my life that this is not written by a doctor. So imagine that you now see something and you saw it's a physiotherapist that you even know and it's posted on social media. You can see how trouble you're going to feel. So please, it is very, very important that we learn this discharge report and know how to use them properly. I said we should try as much as possible to always review every report before we submit them, either electronically or either in the file to go for archiving. You should correct your spelling errors, you should correct dates of the patient's details. You proofread to ensure professionalism and accuracy. You don't want a faulty or a wrong spelling, because this thing I'm talking about, it normally occurs when you write your draft report of a discharge and you give it to a secretary to type. The secretary may not even understand what you write, you just type rubbish, and then you didn't read it, you just stamp and sign. And people will read your name and you don't know where that letter or where that paper will get in life. So please be very, very meticulous. If you cannot give the detail and for typists to finish, read it yourself and work on it yourself. All right, now we've come to our group tasks. In this group tasks, I said we should have orthopedics, neuro, pediatrics, as well as the cardiopulmonary specialist. Now, please, I just need one person to stand up to say is going to be the one in charge of each of this group. One person for orthopedics, one for neuro, pediatrics. So you just talk to yourself in the group, you know. Then everybody has 10 minutes to present the case I'm going to be giving you guys to work on. So please, I need the specialty chairperson to please indicate. If you want to speak for the orthopedic group, please identify. Just point out that I'm going to be speaking for orthopedics. Please, one person. Quickly, let's go. Yes. Who is speaking for orthopedics, please? Come on, guys. It's just going to be an interaction. It's not a big deal. Hello? Who is speaking for orthopedics? Are we tired? Do we need some break? Okay, who's going to speak for neuro? It's a group task. You will have to discuss with your members before you speak. I just needed to know those who are the speakers. Please feel free. Hello.
Yeah, you have to give them some time, let them brainstorm within themselves. Just give them maybe something like a
Okay.
minute.
I think I'm going to show you my questions for each group, so you could choose which group you want to speak for. Is that good enough?
That would be good.
Yes. Now this is for orthopedics. I'm presenting a 55-year-old with knee OA post physiotherapy. Is history, interventions, and progress. You need to provide that for me. So your task is that the group should draft a discharge summary. That's for orthopedics. So I'm going to be giving the orthopedic group 10 minutes to draft and present. Then the same thing for the neuro. You also want to draft a discharge summary for, of course, a 60-year-old woman with multiple sclerosis post physiotherapy. And for the pediatrics, I want you guys to take an example, an 8-year-old boy with CP after your intensive therapy. The functional improvement should be described, and then you should be able to draft a discharge report. So please, I'm giving you 10 minutes to do this. We'll take it at 5 minutes after 3. So we'll continue 5 minutes past 3. Let's move. I hope 10 minutes is okay for the task to draft your discharge report. Is 10 minutes good enough? 5 minutes. Is it that is too much? Let's reduce to 5 minutes. Or we add it to 15 minutes.
Sorry, please. I wanted to ask, how do we interact? Still on this group? Everybody
yes, please,
on mute.
Please, I don't know, maybe via chat or something.
How would you know our book members?
Please, you just chat up yourself in the chat bar that I'm going to be working in orthopedics, or you say you're working in this group. So somebody should agree to speak on behalf of the group. Because I don't really know how easy it's going to be that I want to form the group. I should, because I believe you guys have specialty where you are. And I would have said, okay, Tunde and Najib and all these, I count the first 10, I say you are in this group, another 10. So what do you guys think? I thought you could do that yourself. Huh?
Yeah, it would have been better to break into classes or something like smaller groups where people can interact and come back to this main group to talk about it. Well, I don't know how possible that will be.
Mrs. Tolulokwe, can you do that? To break into some 4 groups and let people do it? Okay, yes, thank you so much. Anyike said she will speak for orthopedics. Yes. Okay, it's Kelechi that is telling us Anike will speak for orthopedics. Is that the point?
Yes, sir. Dr. Suleiman, I mean, will speak for neuro.
Okay, Suleiman will speak for neuro. Anike will speak for orthopedics. So who will speak for pediatrics? We need the pediatrics and the cardiopulmonary group. So please, Mrs. Tolulokwe, if it's possible, help me break the group into 4 groups. You said, just give us some chat. And then it's 2020 per group. I can see we have over 80. So let's put 2020 per group. And then let's just quickly come back, say 10 minutes or 15 minutes after 3, and then we'll continue from there. Thank you.
Sir, for the breakout session, it may not be that possible because the host only has the capacity to do that, and he has to have a laptop or system which he will be able to
do that.
control.
Unfortunately, I have only one laptop by my side here, and I won't be able to do that. So please, let's just think about something we could quickly do. I just want us to do try to see if we can use what we have learned and put it into practice quickly. Let's just do something.
Can I say
something?
sir? Can I say something, sir?
Yes, please, Dr. Fine, go ahead.
Yes, what I want to suggest is that since we have some of us here who have volunteered to speak on a group,
on behalf of the groups, yes.
Let them just do it, then we now critique it. Generally.
Exactly, because that is the essence, like I mentioned earlier in my presentation. We'll present per group and then we'll critique it ourselves and then we'll learn and then we move forward. That's it.
Yeah. So those who have showed it.
So, but I've already had only 2 people, Anike and Suleiman speaking for neuro. I need 2 people more to speak, one for cardio, one for pediatrics.
Actually, I think if we want us to go into groups, we can actually private chat ourselves. So on each person's profile or something, name something, I don't know if you're using a laptop. If you click on each person's name, you see 3 dots, and then it says chat the person. You can actually chat privately. So since I'll be speaking for us, I can go to my profile right there. Just click on chat, and you'll be chatting me up privately. I think I've connected with Kelechi now.
Okay,
So
guys, please, she has given us something. Just work with it. I really want us to come back 15 minutes after 3 and then we put it up. Please, let's just move it.
I have a suggestion, sir. If
Hello, are we back? Can we continue now? Are we done with the activity? We? Hello, are we back in the class? Can we start? We're about 20 minutes.
Yes, sir. We can start, sir.
Okay, please, thank you. Let me call on Aike to tell us about the orthopedic aspect. Aike, are you there? Where's Aike?
Okay, yes, sir. I'm here now, sir. I'm here
now.
now.
Good, great. So please tell us something about what you have gone through concerning the orthopedic draft summary. Let's listen to you now.
Okay, so Mr. John Adewale, a 55-year-old male with hospital number 777, is a non-hypertensive with BMI of over 35. He reported to the clinic with complaints of chronic right knee pain 3 weeks ago, with an inability to walk properly, climb the staircase, and squat to use the toilet. Radiological investigation revealed degenerative changes consistent with osteoarthritis. Interventions thus far included pain management using cryotherapy and TENS, RM exercises, progressive strengthening of the quadriceps and hamstring muscles, gait reeducation, balance training, and weight management. Current assessment is an improvement of pain from NRS 7 out of 10 to 3 out of 10. Yes, and an improvement in range of knee flexion increased to 105 degrees. He can now walk independently with minimal discomfort while climbing the staircase. Recommendations are home exercise program, which to include continuous quadriceps and hamstring strengthening, low impact exercise, aerobic exercises, balance training, and lifestyle and management advice. And then for further treatment or referral, it should include follow-up with orthopedic physician if needed, regular physiotherapy review every 6 to 8 weeks if symptoms persist or worsen. And that's all.
Okay, thank you so much. That's quite very, very impressive. I'm happy. I don't know, colleagues, do any person want to have any critique about the draft summary she presented? Do somebody want to talk about any point she had raised concerning the draft discharge summary?
Hello, sir.
Yes, it's just it's all what we call is constructive criticism. Nobody is saying it's wrong, it's failed, or what? No. It's just what are the errors you can raise, and then let's see how we can improve on it. Yes.
Hello, sir. My observation is with respect to prescription of the intervention.
Prescription of intervention. Okay, what is the problem you identified?
Like in terms of repetitions for the exercise given, as the following the fit principle, frequency,
what happened to the
intensity.
repetitions?
It's like it was not mentioned specifically.
Okay, there was no frequency like the fit principle. That is, you did not prescribe the exercise. The exercise is not on the prescription, right? No frequency, no duration, no time of that exercise, no intensity. Is that what you're saying?
Yes, sir.
Okay, thank you very much. It is noted. Yes, any other concern? Do we have any other concern with the discharge summary Arike has presented? I don't know what's happening. Do we feel shy speaking online or what? I don't know. Please, let's feel free and talk.
Hello.
This is just about class. Yes, thank you.
Hello, sir.
Yes, go ahead, please.
It's as if I didn't hear any investigation done. Doing any investigation, maybe imaging or some sort, or clinical, maybe lab I didn't hear something like that.
Now,
I'm not sure.
the
Maybe
question is to Arike. Is it okay? Sorry, is it Arike or Ayike? Is Ayike? Okay. Ayike, are you hearing the speaker?
I can hear clearly, sir.
Okay. Yes. So, what do you have to say about what he's asking about?
Yes, he asked about investigations, right? Yes, I think I mentioned the radiological investigation, X-ray, probably. Yeah.
So did you get that? There was a mention of radiological investigation.
yes, sir.
Okay, thank you. Is
But,
any
can you
other
please,
concern? Yes, go ahead. Go ahead, Mr. Jimo. Are we losing the connectivity? Because it seems to be speaking, but we are not
I
hearing.
think you are Mr. Jimo.
Good, go ahead.
Hello, sir. I think you are the Mr. Jimo. Since anytime you speak, the name Jimo is appearing. That is what has been happening.
Who is now putting
Yes,
that
sir.
Mr. Jimo here? Okay, let me see if it's me, and then I can change my.
And you were supposed to rename your device, sir.
Oh. Okay, thank you. I've seen it. All right, thank you. So let's also listen to the neuro presentation. Mr. Suleiman, are you ready?
Good afternoon, sir.
Good afternoon. Go ahead.
Good afternoon, everyone. Can I start with respect to? This is a brief discharge physiotherapy summary of Mrs. Female with a diagnosis of multiple sclerosis that is relapsing, and she was referred to physiotherapy by a neurologist on the 1st January 2025, which was admission date was 1st January 2025, was referred to physiotherapy on the 1st of February 2025 with hospital number 1234. So on physiotherapy assessment on admission, based on mobility, she was assessed to require assistance with transfers. She had a very unsteady gait. In fact, she frequently falls with walking. Then for the muscle strength domain, she had reduced lower proximal muscle strength, especially with power 2 of the quadriceps. And then the tone, she had spasticity, especially with calf muscles bilaterally, and it has a grading with modified axial scale of 2. Then balance, she had a very poor dynamic balance as well as limited static balance. Coordination domain, she had ataxic movements that was observed on admission. Then on activities of daily living, she needed assistance with dressing, toileting, as well as ambulation. Then physiotherapy interventions during admission were strengthening exercises. Usually this patient was seen 3 times in a week, and the target of the strengthening exercises was targeted at the weak muscles, especially the quadriceps, the hamstrings, and each exercise session involves several repetitions with a 3 sets of sub repetitions with rest intervals. Then for the spasticity, static stretching was used, especially of the bilateral TA, that is tendon Achilles. Sustained static stretching of 30 seconds, 3 sets of 30 seconds repetitions. Then for balance as well as coordination training, she was trained for static as well as dynamic balance activities. And then gradually she was progressed to the parallel bar. Then gait training was also initiated within the parallel bar, and then gradually progressed to the walker. Then education of she was educated in terms of energy conservation as well as fall prevention.
as well as use of assistive devices. Then the individual strengthening exercises was also shown to her, as well as the patient relatives, which will be done in the absence of, on the day of physiotherapy. And this was done by it was demonstrated to her to be doing while physiotherapy is off. Then for status, her own status at discharge, she had really improved in independence in terms of transfer. She can transfer independently without any support from bed to wheelchair, as well as wheelchair to the bed. And then she ambulates with Zimmer frame 2 to 3 meters independently. Then spasticity was controlled with the stretching as well as the positioning techniques. And she has really improved in endurance because she's able to participate in 20 to 30 minute sessions with rest breaks. Then patient and the caregiver trained in self-mobility as well as home exercise program. So the physiotherapy discharge plan now has to do with, she was advised to continue home exercise program, which involves daily stretching, strengthening exercises just as prescribed before. Then she was advised to continue use of assistive device in terms of trying to increase the distance or the length, the distance of her walk. Then finally, she was advised to follow up physiotherapy in terms of outpatient basis 2 to 3 times per week for continued GET training, as well as advanced balance and endurance training. Thank you very much. Before then, finally, this report was prepared by Dr. Suleiman Aminu, is a principal physiotherapist on the day of on this day of 20th December 2025. Thank you, sir.
All right, thank you so much, Mr. Suleiman Aminu. We appreciate you. You see, could you tell us what framework did you use in drafting your discharge report?
Sorry, sir, you said, sir?
I said, can you tell us what framework did you use to draft this report?
The ICF model, sir, framework.
Now, did we discuss ICF today?
Yes, sir, no.
Now, this is where the problem lies. We wanted you to use the model we have presented, and you could see when Arike presented, how was cute, time, it was quite encompassing, and it was based on summary. But because you were using a different model, it became lengthy and much difficult to follow, So we wanted you to learn the SBRA framework and then impute all this. We want to see that you have made use of the situation, the background information, the assessment, and recommendation. That would have been much more easier and very straight to the point. Then we would have been able to follow you appropriately. Nevertheless, you did a good job. You were just too elaborate, and information that were not needed were all put into this your discharge summary.
Okay.
So I'm sure other people will wonder when they read it somewhere, like, what are we having here? Is it a clerking, or rather is it a form of discharge? So you didn't put it in a way the discharge would have demonstrated that you are discharging this patient. At the end, you see there was no closure of that situation that you have presented. Okay? So there must be that closing remark that will define that this is what you have presented, and the next person following up or taking over the care will already have all the background information that was needed to work on the patient continuously. But nevertheless, we thank you very much. We appreciate you. Other members of Neuro, do somebody want to speak and bring up some issues that we would like to correct? Any other member of Yes.
I think even though he didn't follow the S-bar method of discharge planning, I mean discharge summary,
Yes.
I think he did a work. Only I noticed there was supposed to be like when you were talking about the functional abilities,
Yes.
was supposed to use outcome measures. Though you mentioned FIM, but FIM is not normally, sometimes we don't use FIM in neuro, sometimes we use battle index, but we use FIM is a generally, but in neuro we prefer because this thing is more easier. Battle index is more easier, and when it comes to the SMART goals, what do you want to achieve for your patients? And so sometimes we can use, instead of using just the functional independent measure, we can also use a battle index rather than just explaining all the function. You can sit to stand, you can transfer from this, so just use that one. I think it would have been easier to use that one than than doing explanatory functional evaluation. That's my own input. Thank you, sir.
Okay.
Thank you so much. Do we have any other one? We're already behind schedule. We have just about 20 minutes. Somebody from pediatrics want to speak? Do we have any person from pediatrics? Is anybody going to support the pediatrics presentation? Do we have somebody for the pediatrics presentation, please? Like for the neurology, you see what I say you should do? I say you should include the progress in the ADLs, mobility and communication. You'll be able to document outcome measures like the film scores, then write recommendations for community reintegration. So Suleiman, please try to put this in on to your plan, okay? All right, good. For pediatrics, I talked about an 8-year-old post-CP child that had gone through intensive therapy. Of course, we talked about he has improved in function. So we want the group to draft a discharge report for the baby. Is anybody there for us? No pediatric specialists in the group? Okay, I will just let it be slide. So people will just try to read it up ourselves. After getting the situation, you should be able to tell us a background, what happened, was it during delivery, post-delivery? Okay. Ayomide, do you want to talk about the pediatrics? So you should be able to give us the situation of the baby, at what age that the CP started, was it post-delivery, what happened and all that. Then you talk about the assessment you did, what was the spasticity, muscle power, then the balance, and then whatever the patient can do, the ADLs, and then we talk about the progress from when baby came in and to when you're able to pick up some function and participation in the baby. And then you provide recommendation for parents as well as schools, what they should do. So all these are the things we really wanted to hear in that baby's case. So I said what I hope we have gotten in our group presentation, that each group will present its draft discharge report. We will listen to them, and then we will be sure that do they follow this checklist structure we have described, the S-bar. You have that. So that's what we wanted to pay attention when we give you 10 minutes to present your cases. And of course, your colleagues should have been able to evaluate each of you based on the S-bar. And of course, our concern will have been to focus on the clarity of your presentation, the completeness and the professionalism you have shown in writing the discharge. And of course, all our feedback, we wanted it to be constructive and supportive. So those are the things we're trying to do. So therefore, for today, we have seen that the strength of a discharge report involves ensuring that you use a framework like the S-bar framework, And then we could see that if you don't use the S-bar, you're going to be likely going to have errors in the presentation that we did. So I want us to all understand that an effective discharge report should be clear, structured, and complete. And of course, when you do a good discharge report, it will continue to be used as a support for continuity of the care. And of course, it shows accountability of whatever you have done. And then it gives that spirit of teamwork for every person to read and know. This discharge summary can protect both the patient safety and, of course, professional practice. We have demonstrated all of them today. And therefore, I want us to go back into our practices from today and see what we will make as a discharge, what will change in our practice in terms of discharging our patients. And of course, what do we need to do to improve how we discharge our patients? And of course, I want you to see whatever you have learned today. Can you go back to your clinic and share with your friends and other colleagues in there so that everybody will begin to understand how to discharge their patient. So I thank everybody very much for listening and participating. Appreciate, and of course the MRTB on their behalf, we appreciate your active participation in this continuous medical education workshop. And I hope from this moment we'll be able to write effective discharge reports. That's to strengthen our profession and enhance our patient care.
Thank you very much.
And I invite your colleague, Professor Bishop. That's my email. If you have other queries, questions, and collaboration, please feel free to reach out to me. I thank you all. So I'm ready for any questions you want to ask for the last 5 minutes before we go.
I have a question, sir.
Yes, please go ahead.
Yes, sir. In our clinics, really, a lot of times we're faced with patients who have been attending our outpatient clinics for years without discharge, right?
Sometimes some clinic will like, I've been coming here before you graduated, when you were a student. So a patient will tell you that, you know? So we keep patients for years. Please go ahead.
Yes, we keep patients, and I'm talking in particular about knee osteoarthritis now. And these are probably, conditions that physiotherapy can do little or nothing about.
That's right.
But these patients keep coming for years and years with the same complaints. So there's still pain, and we're not discharging them. I'm wondering what an ethical, ethically is this right, and professionally is this right? Yeah, for you to be treating patients like this for years without discharge.
Thank you very much. That question is quite relevant, and then it tells us the basis why we must have a discharge report pattern. Because the essence is not for you to keep a patient, maybe because you are benefiting in the payment of the patient, or because you are formed a family and social interaction with the patient. No. The reason why patients keep coming for donkey years is because the physiotherapists in the first place do not have the goals and objective of keeping the patient. When you have a patient, and that's why we keep talking about creation of goal. What are the goals you want to achieve for this patient? You know, if those goals have been met, then patient must be discharged. Discharging your patient does not mean the patient should not seek for care other places or from further professionals. You must delineate and create a clear pathway that these are what you want to achieve from these patients. So if you've been able to reach that, then fine. And now if the patient's condition did not give you the opportunity to reach those objectives, you must document these are the reasons, and this patient had picked. You cannot go from here. You have to discharge the patient to seek care other places. Otherwise, it becomes an unethical practice. Number one, you are not giving patient information to seek care elsewhere. Number two, you continue to collect. If you are collecting money, free. It's still a disservice to the patient and even to the professional. So please, it is not appropriate, it is not right for you to continue to manage a patient who is not making progress and you keep leaving the patient in the department. You can even refer patients to other senior physiotherapists or specialist physiotherapists. So you don't keep them to yourself. Thank you very much for that question. Yes, Mr. Suleiman, your hand is up.
Yes, sir. Good afternoon, sir. Please,
Yes,
with respect
welcome
to this question that this colleague asked,
yes,
sir, can we have it as a goal to prevent further complications such as, for example, joint stiffness, muscle wasting, in a condition that tends to be with very poor prognosis, just as I asked in the previous class. So can that be as a goal? And if it is, so can that warrant a patient to keep coming for physiotherapy for those just for us to achieve this goal, or just to maintain the patient in a situation where he is right now, so that he cannot, or he will not deteriorate further? I don't know if
just take
my
an
question is.
example of the case she presented. And
Sir?
I said, take an example of the case the lady presented earlier. Is an osteoarthritic patient which has reached an advanced stage, and there was no any progress in terms of either range of motion or in terms of the functional ability of the patient or pain management. All you're doing, nothing is changing in that patient. Will you keep keeping the patient that you want to prevent other further deterioration? You are supposed to send the patient to another care, because the next thing after the advanced stage is for patients to go through what they call a complete or total knee replacement, because that cannot come back. Now the patient tells you, I don't have the money, I can't do it. So what you're expected to do is now send the patient to another care. You don't have to keep the patient. He must know that you have discharged him from work, so that he does not believe to keep that there's something you want to do for the patient separately. Even if it means sending the patient to another physiotherapist, let him know that you have picked with his management, and therefore he needs another care. So he goes see something or someone new. If that other person can offer something new, then that's be it. So don't keep the patient to yourself for life. Don't keep the patient in your clinic for life. Send him to other clinics. Thank you. Any other question? You can put down your hand, Suleiman. Yes, any other question? Well, if there are no further questions, I really want to thank everybody. And Dr. Fine has been my wonderful colleague who started the presentation. He has made life very, very easy for me. I didn't have to write so much. He has done all the whole work. So Dr. Fine, I really appreciate you. I thank you so much for the morning presentation. It makes the afternoon one much easier and much simpler. Okay, so I hope we'll be able to come again and still continue to disseminate this same information somewhere else, in other topics that are supposed to be covered by our CPD. I appreciate everybody who've been able to stay glued together. It's quite impressive. You can imagine we started with about 70 and we're closing with still about 70. So that's a wonderful thing for me. So I thank you all, and we remain blessed. Have a wonderful evening. Thank you, everybody.
Thank you, sir. We are very grateful, sir. I think at this point, we've come to the end of the workshop. Have a wonderful weekend. Bye.
Bye.
Bye, everyone.
Bye. Bye.
Thank you. Bye-bye.
Please, I don't know if the moderator will help us get the presentation material, especially that of the first PCV as well as this one, because for the first one also I didn't get my own. Thank you very much.